So testing my competency now in microphone usage. So welcome everyone to the next session. We are going to be discussing understanding past and current performances of the nation's laboratory systems. My name is Kendra Ford, Vice President of Clinical Services Operations at New York City Health and Hospitals, and really happy to be here and really thrilled to be with our amazing set of panelists. We're going to be discussing factors that influence the performance of our nation's laboratory systems for our public health emergency preparedness and response. And during this session, several speakers are going to share their stories and examples from our past events beyond COVID. So I'd like to introduce our panel: Christina Egan, Deputy Director, Division of Infectious Diseases and Chief Biodefense and Mycology Laboratories, Wadsworth. Rob Middleberg is the Core Laboratory Director and Senior Vice President of Quality Assurance and Regulatory Affairs at MS Labs. And Scott Schoen is the Director of North Carolina State Laboratory of Public Health. Ewa King is the Chief Program Officer at the Association of Public Health. And Joe Anelli is the Executive Vice President of the National Association of Federal Veterinarians. All right, at this time, I'd like to begin. Christina.
Hey, thank you very much, and I really would like to thank the Planning Committee for inviting me to speak on some of the experiences we've had at the New York State Department of Health Wadsworth Center, which is our New York State Public Health Laboratory. So a little bit about myself. I have been at the Wadsworth Center since 1999, so I have lived through a number of different outbreak responses and events. I oversee we talked a little bit about the LRN. I oversee the LRNB activities at the Wadsworth Center. And I'm going to talk about, let me see, I'm going to spend some time talking about two events. One a long time ago, but I think it's very important that we talk about some of the events, especially the intentional release of Bacillus anthracis through the U.S. mail system, and then some brief comments on Mpox that we were involved with last year. So I always like to start some of my talks with this slide, and 1999 was a very significant year for us for a number of reasons. One, we at the Wadsworth Center was one of the labs that received a Public Health Emergency Preparedness Cooperative Agreement. And as part of that grant, 4 scientists, I was one of them, was hired to take part in a bioterrorism response team. So we were training, we developed assays, and remember at this time the LRN was just getting into existence. So there were no protocols available to our laboratories, test kits weren't available, but there was communication with the CDC LRN at that time. But in 1999, we started to receive biothreat samples. And this is the first one we did receive. And at that time, there were very few labs receiving biothreat samples. Our first sample, this actually came from Vermont. So we were doing testing for not only New York, but some surrounding areas. This sample was sent to us by the FBI, our local FBI. And at that time, I don't even think he was called WMD coordinators as they are now. But the sample was a threat letter that was received from a Planned Parenthood with powder in it. It was sent to the laboratory. We had told them, just make sure, you triple contain the sample, and they triple contained it all right in duct tape. And so this was our first foray into working very closely with our local FBI as well as our New York State Police and other response officials and team members to do some training. And so over the next 2 years, what we had done within our laboratory, and as well as with our partners. We trained with them. We developed protocols. So when 2001 hit, we actually had a molecular assay that we utilized for testing. We were one of the very few labs outside CDC that did have PCR capability, although at that time it was conventional PCR. So the turnaround time was, and this is going back reviewing this event brings back painful memories. And shown here is our one area of our BSL-3 laboratory, and you look at the various types of samples we were given are sent to the lab. We had steel drums, we had all sorts of things, and so processing these samples is something that we can't lose sight of, and this is something that is very difficult to get around when dealing with environmental samples. You have to have the ability to process those samples. So high throughput in this type of scenario is very difficult. But, 2001 rolled around and we had a team trained, ready to go. We had protocols, we had communication, we thought we were all set. We had actually renovated our lab, so we tripled the size of our high containment lab. And then 3 weeks after the horrific events on 9/11 occurred, and thinking back on that, that was 3 weeks after, we had the first case down in Florida, and that started samples coming to our laboratory as well as other public health labs. The next week, we had a positive in New York City, and that led to just a huge number of samples for our laboratory. The other issue that we had, and if you ever have heard Sally Beatrice, who is a former director of the New York City Public Health Lab, we tried to do all the training we could, but down there, they had the loss of their valued first responders. So not only dealing, we always think about things, in isolation, but, we have all of these other factors that play into our efforts in response. So training new individuals during this time. These are samples that were brought up to our lab from New York City, and over that time we had 1,000 samples from October to December. 33 were positive. Overwhelming amount of worried well samples, both environmental and clinical samples. So thinking about this was, a very complex event. We had clinical specimens coming in. We had to do environmental testing as well as surveillance for investigations. Some of the lessons learned, we in New York State, the state actually hired 20 laboratorians because they took this so seriously. We had a response team of 20 individuals, state hires, in bacteriology, virology, emerging threats, and what we did was developed assays. We didn't just sit around. We developed assays. We performed testing, routine testing, and as we talked about being able to turn things on and off, these individuals were trained to be part of our response team. Through the public health FEP, what we call the cooperative agreements, we did get increased funding, and we used that to purchase equipment and supplies. And I mentioned, we continue to create and develop new tests so that we have tools available. We were able to bring on 2 of our county public health labs, so we increased our capacity. We had 4 public health labs. To date, we still have them. But to note, environmental testing is something that we still, we don't talk a lot about, but we still have to keep that in mind. And what we did in New York is through our 2 programs, we have a clinical regulatory program as well as an environmental lab program that permits labs that perform environmental testing, and they use ISO standards for that. We established a process for labs to be able to perform environmental testing for both biological and chemical threats. And we had about 14 labs that actually went through the inspections and surveys and took part. We are now back in 2023, back down to those initial 4 public health lab. And then we also, through our clinical standards of practice or regulatory practice, we established 2 standards that clinical laboratories have as far as LRN protocols and maintaining inventory and select agent regulations. So I want to quickly talk about MPOX. Some of my other colleagues up here will be speaking about this, just to kind of compare and contrast. Forward 20 years, we had another lab renovation, but what we did have in this time, we heard a little bit about an all-hazard receipt facility. We actually had one that was funded through Department of Homeland Security. We actually trained other federal laboratories as well as our public health laboratorians to use that. So those samples are screened in that facility and then brought up to our high containment laboratory. But getting back to monkeypox, luckily we did have that FDA cleared assay, which was very helpful to have that. We had trained personnel, and I think different from in this response is really close communication with CDC and LRN. We had weekly calls, bi-weekly calls, really close communication. And I want to talk about, we were, I guess, instrumental in the early response. But boy, when it came to July and our friends in the commercial labs came on board, especially in New York, it was just a huge relief to us. And they, were so invaluable during that time. One of the other things that we did was through our regulatory program is we had developed laboratory LDT guidance for testing because we knew we need additional capacity for some of our clinical laboratories that wanted to perform testing. And so by June, we had guidance available, and we had 12 to 14 clinical laboratories that started to perform testing to provide additional laboratory capacity, which was very helpful in New York due to the large number of specimens. But just to talk a little bit about what didn't work, the lack, we've heard this multiple times, no fully automated MPOX assay was really difficult because the time that the laboratory staff had to spend with this was very time consuming. We also were working in the BSL-3. Now we are going to be moving to BSL-2 with some of these fully automated tests that are now available. Another thing, so the public health labs, not only do we have to get involved with testing, but we are also tasked sometimes with communication with our clinical laboratory colleagues for providing assay validation materials. And, we were contacted by numerous laboratories for assay validation specimens, materials. So also in New York, I would say a lack of capacity or lack of access, and that is because were some providers that didn't understand the protocols we use in public health, going through our epidemiology colleagues to identify cases and specimens that should be sent to our lab. I know I'm not supposed to be talking gaps, but I wanted to put a few things out there that we really need to kind of think about is the lack of environmental laboratory testing for biothreats. Another thing that is critical that we saw back in the fall, availability of testing for agents such as hemorrhagic fever viruses. This is something that I think we can really overcome, and we should have these available. And I think both in the clinical labs as well as public health labs. And we also mentioned a little bit about the lack of consistent funding. So, in New York last last summer was difficult. It was very, very difficult dealing with keeping up with our SARS sequencing, analyzing that data, Mpox, polio. I mean, it was one thing after another. So having some type of funding that can be utilized for multiple purposes would be very helpful. And that's the end of my presentation.
Good afternoon. With all the high-level individuals, other panelists I've heard so far today and those coming, I'm still trying to figure out why I'm here. But nevertheless, I am from NMS Labs, which I think, to my knowledge, is the largest private esoteric bioanalytical toxicology laboratory in the United States. We've been doing this kind of work for about 53 years now. So we didn't just fall off of a turnip truck, that kind of a thing. Also, as a member lab, along with many other smaller and mid-sized laboratories, we are members of the National Independent Lab Association, which represents us. We unfortunately don't get a large voice in some of the other organizations, and this is the best we can do. But it is indeed an honor and a privilege to be here. As a laboratory scientist, I'm kind of thinking this is the closest to the National Academies of Science as I'll ever get. I'm so used now to having to have a disclosure slide. I just put it in. One day I hope to have something there that has made me independently wealthy. Hasn't happened yet. So I'm going to start with this. Some of you may be familiar with Stephen Covey, and he wrote a pretty well-known book, The 7 Habits of Highly Effective People, and start with the end in mind, and I will get there in a second, the end. So imagine you're the lab director of a lab that I just described, and your phone rings about a month and a half ago, and you hear this. How fast can you do 30,000 vinyl chlorides and ethylene glycol monobutyl ethers? We need them done quickly. Well, certainly one response is this, but that's not a very effective response, to be frank about it. So what do you do in situations like that? The best you can do is analytically have validated methods and be agile in development. We've heard a lot about that already today. Have highly trained staff and have a willingness to help. I will tell you, as maybe the largest toxicology lab in the country that does esoteric work, we have about 1,000 tests that are locked and loaded and ready to go. The Chemical Abstract Service has registered over 182 million compounds. 1,000 compared to 182 million doesn't touch anything. But you just can't have 182 million tests waiting. You just can't do that. So practically, which is what I have here is the antithesis of what this is about, but this is focused solely on environmental and occupational disasters. A lab can't really be prepared because of the 182 million compounds. You do the best you can. That's what you do. It helps to have a 40,000 square foot laboratory with 200 chemists who are highly trained and over $20 million worth of very specialized testing. That helps, but it doesn't fix all the issues. And it's always easy to say no when somebody calls, can you do 30,000 vinyl chlorides? But that doesn't help. That's not why labs exist. That's not what we're about. We are here to address issues and problems, as we're hearing all throughout today. So I thought I'd give you some examples of some of the things we've experienced. And you're going to hear me talk about thousands of samples. And I know compared to COVID, where there were millions, hundreds of millions, that doesn't seem like much. But these tests don't have point-of-care testing. They don't have automated methods to do it. These are all very heavily labor-intensive, using very, very specialized testing instruments that cost sometimes $500,000 to $1 million a pop to be able to do this kind of work. So with Deepwater Horizon, this is a large oil spill 41 miles off the coast of Louisiana, lots of oil everywhere. And unfortunately, wildlife was terribly affected. more than 47,000 rescue workers were assisting with this spill response. So usually we get calls about this, so we decided to be proactive and develop a testing panel that we thought would cover a lot of the landscape here. To today, we haven't gotten one sample. So this kind of work isn't field of dreams. You don't build it and it comes. You hope it does, but it doesn't necessarily. Now let me show you ones where it did come. So the World Trade Center in 1993, many of you might remember, this was the first explosion. A van bomb in the parking garage exploded. There were more than 50,000 people in the World Trade Centers on that day. Immediately, the electricity went out. Smoke filled 93 floors in both towers. So we were asked to analyze hundreds of samples of people trapped in elevators and other places for volatile organic compounds. This is the kind of work you're sort of prepared to do in those kinds of emergencies. And then, of course, unfortunately, on September 11th, 2001, and the months after, we saw the continued disaster at the World Trade Center, irreparable, obviously. But what we were asked to do is immediately bring up testing to be able to handle 11,000 samples for mercury, beryllium, and PCBs, polychlorinated biphenyls. Not the kinds of tests I know we're talking about mostly today, but these are very labor-intensive tests. And we were able to do it. And the only way to do something like this is to have good relationships with your vendors, instrument vendors, supply vendors, to ramp up in a hurry. We had standing tests for these substances, but getting to 11,000 in a hurry is really, really intensive, to be frank about it. And so you might say, so why mercury? Most people don't realize that not until too recently, light switches had mercury in little glass capsules, and it was the movement of the mercury that connected the electrical ability for a switch to operate. So all of these people were at this site, all the rescue people and cleanup people, all being exposed. PFAS, many of you may have heard of PFAS, polyfluorinated alkylating substances or alkylated substances. This is an ongoing concern in the United States. You can see the map on the bottom there. All the dots represents places that have been identified having a PFAS problem. These are known as forever chemicals. They don't go anywhere. The equivalent of modern DDT in some way that Rachel Carson wrote about in Silent Spring. Right next to us, where our headquarters is Willow Grove Air Force Base, or Naval Base, I should say, totally contaminated and shut down. Nobody knows what to do with it because they're in firefighting foams, and they were using them all over the place. Neighborhoods have been contaminated. People are wondering what to do. There's over 9,000 of these. You can't analyze for 9,000 of them, especially in humans. Luckily, this august body, the National Academies of Science, came out with a report in July of 2022 that addressed this, that gave some guidance on what to look for and how to do it. And it's really summing 9 of these, over 9,000, the ones that are most prevalent in humans. So the question becomes, do you need to be a CLIA lab to do this work? We've heard about CLIA today. I think so. We're a lab that has a CLIA license. We have 2 ISOs, ISO 15189 through the CAP and 17025 through ANSI. We think this is what it takes to be able to do this work, and again, being used in the treatment and diagnosis of patients. We've done thousands of these for federal agencies, for state and local agencies, and for citizens. But what's interesting is, with this disaster and all the others, a couple more I'll show you, you can't force people to get tested. Testing can be offered for free, and they won't go and get it done. It's interesting. March 17th, 2019, ITC Deer Park, Texas. A holding tank exploded. And there's a lot of contamination. The cloud plume spread all over the place in Houston, and people were worried. So we were asked to do more than 1,000 benzene phenol analyses. We didn't even think it was the right testing, and we couldn't convince the people who were asking to do the right testing. But we did it. We did this testing. And that's part of the issue here. As a lab, you have an obligation to tell people what's right and what's wrong. But you can't force people to do it. So some of the things we confront with environmental and occupational disasters. And again, 1,000 doesn't sound like a lot, but for this kind of work, it is. And the last one I'll show you is something a little bit of a left turn. And in 2018, 2021, may have heard of SPICE, synthetic cannabinoids, that are out, unfortunately, being abused in the world. Well, somebody out there has gotten the idea that they should lace these substances that people abuse with brodifacoum, which is a super warfarin. And the first thing you see are people showing up in hospitals with uncontrollable bleeding from the nose, from the mouth, from the ears, vaginally, internally. It's a nightmare. And I say these are disasters, and when I show you, it's 214 people. But in 2018, this event just about wiped out the entire country's worth of vitamin K. And clinicians were not allowed to use veterinary preparations, even though it was available, because it wasn't cleared by the FDA. People who get treated for this have to be treated for months, sometimes up to a year, because the half-life of brodifacoum is so long. So there were 7 deaths from this, got a lot of samples from people, and the clinical lab's responsibility here is to do the testing, because you can guide when somebody doesn't need vitamin K anymore by their concentration of brodifacoum. So the major issues to round this out that I see that I think are worth noting is, again, I'd already talked about the millions of compounds, 182 million that are known, and that you can't be prepared for that. There are limits to the science. Yeah, I get endless calls back. Hey, somebody was exposed to chlorine or hydrogen or nitrogen. What can you do? Not much. Not much. And we've already heard about logistics and coordination, not just in terms of collecting samples and getting things together and reporting of data, but what do you do as a laboratory when you're confronted with this, the internal logistics? And is a lab a lab? I'll tell you, in these events, labs pop up left and right. They'll do the testing. They don't have a CLIA license. They don't have anything, but they'll do it. And government agencies will go there for some reason. I don't get it. And the big question is, what is normal? Trying to find out what is a normal level in somebody of some of these things is very difficult. And you might say, so why do the testing? Because people don't underestimate the psychological impact on people to know that they have a level that seems to be relatively normal. That means something to them. What are the clinical actions that follow after reporting a result? And that's difficult because you don't, again, necessarily know what's normal. And we've already heard about this. Who's going to pay for this? So lastly, I'll leave you with a few things. Somewhere in the world, every single day, and I can tell you about them, where they are, a lot of them, especially in third world countries, there is an environmental or occupational issue every single day. Labs can have tests ready for all of the possibilities, but you can't be prepared as to what to do. You have to be agile, able to quickly develop tests, validate them, and get them online. That you have to be prepared to do. A lot of joint efforts have to happen, from the people out collecting samples, to the patients being willing to come and get them, to the transport, to this, to that. It's got to be a group effort That's my experience. And lastly, I hope if nothing else comes out of here, what defines an emergency or a disaster? Is it only the millions of COVID samples, or is it 200 Brodifacoums? I'm not sure what the answer is. But in my world, the little world I live in, 200 Brodifacoums is a disaster. Thank you.
Rob, thank you. All right, Scott.
Great. Thank you. So thanks to the Planning Committee and the National Academy for letting me speak today. When they told me I had 10 minutes to present on the laboratory systems response to COVID and Mpox, I thought they were joking, but they weren't. The good news, though, is that most of the morning panel did talk a lot about what I was going to say, which I think is important to show that we all recognize the same challenges exist, or better yet, the same opportunities for permanent improvement exist moving forward. And the challenges and successes of our laboratory's response to COVID and Mpox overlap. But there are some true distinct differences, and some of them were highlighted this morning, and I'll try to point them out during my discussion today. I included some pictures, like Christina, of my team who were responsible for both COVID and the Mpox response, and they span all disciplines. We talk about workforce, and we do focus a lot on the laboratory disciplines, the medical technologists, microbiologists, chemists. But you'll notice pictures here of our procurement team, of our data entry team, of our warehouse team, of our outreach team, of our IT team, all of which we suffer from the same workforce development issues as well, and they impact the laboratory. When we tour people through our lab and talk about jobs in the lab, I find it just as imperative to tour them through the administrative areas, so that student in high school who likes to do accounting can say, I could come work on the budget for the next large, hopefully, ELC grant or something like that. And so it doesn't just have to be someone who gets a PhD in molecular microbiology and immunology, like me, but it could be somebody who has an associate's degree in accounting who can help with the next lab response. It is always dangerous to put quotes in your talk, but I laugh in the face of danger. But I Googled these quotes, and it turns out none of them are by the people who I thought they were by. So I'm not even sure this is right, but I put it in here, especially the first two, those who cannot remember the past are condemned to repeat it, and those who fail to learn from history are doomed to repeat it. Always reminds me of our response to every public health emergency. And we're sort of in the same place we were after everything that we've talked about so far and what we'll talk about for the rest of the day today and tomorrow. But it strikes me that the laboratory response and the public health response in general is more like insanity. It's doing the same thing over and over again, but expecting different results. So we respond, we throw billions and billions of dollars and hundreds of thousands of hours and tens of thousands of people to get us back to a place of steady state. And then a few years later, we decide to let it all go away. And then we're shocked when we have the same thing happen again with a different or even the same thing. And so I am thrilled about this effort at the National Academy, which I hope will stick more, and I'm pledged to do my job to do it. I'm going to talk about some challenges, but I think it's really critical to start off by talking about success. And there was a slide this morning, there's several slides this morning on the successful testing. We performed over a billion NAT tests for COVID in the last 3 years. We talked about all the challenges that get started, and that's partly because we have institutional amnesia, or actually we don't. The people who are in our system don't have institutional amnesia. The people who we rely on to provide us the funding and to make the policy decisions, they're the ones who have the institutional amnesia or decide that there's something else more pressing in their face that needs to be resolved. But 1 billion tests performed, and this is as of yesterday on the CDC's Great COVID Tracker. This is only NATs, right? So this doesn't even include antigen tests, at-home tests, any of the other tests that came about as a response to COVID. And then on Mpox, in the last year, 143,000 tests. for a test that started out just as an LRN lab test. We heard about the LRN earlier, this non-variola orthopox test that then spanned to some of our clinical partners. And there were some hospital labs, at least in North Carolina, that we worked with to get non-variola orthopox testing up and running to help share the burden. Because, we went from testing one non-variola orthopox sample a year in North Carolina's public health lab to testing 40 to 50 a day, 5 to 7 days a week. I mean, that's public health preparedness, and we just did it, right? That's the public health lab. Scott talked about it earlier. Now, quite serendipitously, that's a word, a great analysis and commentary came out in the Journal of Health Affairs this month. One of the authors will be speaking here tomorrow, Jill Taylor, on planning for the next pandemic and looking at the lab system's response to both COVID and Mpox. So it helped me a lot prepare for this and get to only having 10 minutes worth of slides. But there was a key quote in this article that said, the pandemic exposed weaknesses in the design of the U.S. laboratory system to respond to a fast-moving pathogen. And it kind of gets at that, is system the right word? I tend to agree with Scott, but I like the coming together this morning of ACLA and APHL on the discussion of systems within systems of laboratories. But the reality is that the system that exists, that was described this morning, is not sufficient, as we saw, to respond particularly to a fast-spreading pathogen like COVID, like SARS-CoV-2. And so this was discussed earlier, but I share it in the to sort of articulate that everybody had a role in the COVID response as well as the Mpox response. We had some of our academic partners talking to us about Mpox. They didn't end up doing any testing, but it was part of the relationship building that happened out of COVID that led us to having discussions with everybody when any of these things have come up. And so the public labs, government operated, the public health labs or VA labs, as was said this morning, high complexity, low volume testing of little commercial value, right? You don't make money in public health, you spend money. And so it takes money to keep the capacity running so that we can initially respond and then hand off or partner with or hand hold with our commercial and private labs who have the high capacity, high throughput when the commercial value is there, as long as there's funding for it. And so each of these three aspects, and I'll just want to be clear, I grouped our commercial labs, our hospital labs, our academic medical centers into the private bucket here. I don't do that to demean any group. It was just easier to break this down into really three areas of discussion. And so, so in the response to COVID, these three areas, these three groups participated in method development, participated in actual diagnostic testing, screening testing, surveillance testing, development of wastewater and expansion of wastewater testing and sequencing, and variant detection. And it was only, and I'll speak for North Carolina, it was to our benefit that we brought a group together. Our governor had the foresight to say, let's have a COVID testing task force that came together and looked at this and proactively thought ahead of where could we divide up our limited resources to the benefit of the citizens in our state. And so what I'll talk about moving forward, while from my perspective as a public health laboratory director, encompass, I think, everybody's experience in these three buckets. Before I get to really the meaty slide of it, and this was another paper that came out last year from Christina Potter, who's at my graduate alma mater, the Bloomberg School of Public Health. And this was focused on the operational challenges and solutions in public health labs. But again, it does apply across all aspects of the laboratory system response. And I'm not going to stay too long on this slide because I tackle some of these points moving forward. But you can see that in general, through their interviews with many of us and many of my colleagues in the public health lab director roles, that there were issues across multiple areas that impacted our response. And so this is where I want to spend really the last few minutes of my time and talk about really 8 areas that I think impacted our COVID response as a laboratory system and our response to Mpox. Regulatory issues were clearly a big challenge. There are multiple federal agencies, and early on, there wasn't a great national strategy that we could point to and lean on. And so there were guidance documents that came out associated with these regulatory issues that sometimes conflicted or were slow to come out because conflicts had to be resolved. The public health emergency declaration for both COVID and Mpox helped a lot, right? I mean, it helped a lot. And then as we heard this morning, when it didn't help, there was enforcement discretion. But that still led to confusion. Can I do this? Could I get cited? Could this be an issue? And there wasn't always a clear-cut answer as to why. And on the regulatory side, we heard this morning that there was an expedited review of CLIA applications, which helped remove a barrier, but was seen as an opportunity for those who were a little more nefarious, such as the bar in a part of North Carolina that was doing rapid tests because they got a CLIA waiver right next to serving some good old moonshine. So, and so there were some challenges, and inevitably people will exploit the system, particularly in times of crisis. On the guidance side, let me just point out on the regulatory side again, which I'll get to towards the end, is data, right? And we talked about it this morning, these data elements, and who has what authority to collect what data needs to be resolved pretty quickly. Because it's been said a couple times this morning that this sending the public health lab data is a barrier. I just want to say that we don't ask for it, all right? Our partners in the epidemiology side of the house ask for that data because it helps inform the response. I'm not saying they don't need this, but we collect it because then we send it as a whole package of the data with the lab results. And so it's a constant discussion of what's needed. So on the top of my list, I know we're not supposed to talk about solutions, but on top of my list is figuring out what's the minimal data set to get us going, to remove that barrier for submission, and so that everybody's not on the news saying, I would test, but the public health system is just so challenging. And because the national guidance was slow to change and adapt with data, or a lack of data because it couldn't be collected, we had a patchwork of different guidances across jurisdictions. And I mentioned before the governor's task force in North Carolina, we were at the forefront of antigen guidance when that came out. How do we use it? Who do we test? When do we test? How often do we test? With what test? NAT, antigen, et cetera, while we waited for some of that national guidance to make its way through clearance, which I know is a burden. But clearance needs to be addressed under a public health emergency as well. I'm not going to belabor the test. All I'll say is that there can't be a single point of failure for development of tests in a public health emergency, and that these tests have to be scalable. And it's informing everything we do now, right? So now as we're looking at what's next, we had the burden of not scalable with COVID, we had the burden of not scalable with Mpox, and we have the burden of not scalable with Ebola. But now we're thinking about, and I will speak from my lab, is we're now looking at CORIS. So we're looking at how do we test hundreds of samples a day as opposed to just the one-off, because if one patient has it, dozens of patients are going to have it. And that's the mindset we have to work with, and that's the test development needs to be scalable. We have to do the onesies and the twosies, but we also have to do the thousandsies, and that's where we need to get to. And we were a little slow with sequence and variant detection. We lagged behind other countries on that. But the good news is a lot of money's been poured into this, and our colleagues around the country, both in the laboratory system, have developed this capacity. The supply chain, I don't want to belabor this, but I want to point out one thing on the supply chain is what Scott Becker said earlier is we need to identify those tests that still have to run, but use the same supplies. Because we can't jeopardize the health of newborns during a global pandemic. We can't jeopardize the ability to test for HIV or for prenatal syphilis because the same pipette tips or the same plates are used. And I can't tell you how many times we talked to a vendor and said, I'm sorry, this is going here for COVID testing. That just can't happen. And I'm not a supply chain expert, but I do know that there's got to be a better way. I mentioned data already, and a lot of us are getting away from our fax machines, I promise you, but they are still out there. Old systems, and not a lot of people coming into government IT, because we can't pay as much as everybody else. And they make a lot of money. I love being a lab director. Sometimes I just wonder if I should have taken those Saturday morning IT classes a little more. And then finally, workforce, which I already said, technical and non-technical. The historical lack of investments in public health and medical laboratory professionals. We had a history of having fellowships and internships, and they stopped being funded because the institutional amnesia kicked in. And now we have millions of dollars for fellows. We have to continue that. And we have to bring them down into like middle school and high school. My son is in second grade and he won the second grade science fair. Now, yeah, his genes might articulate a better propensity. His mom's a microbiologist as well. And so, but the reality is he's become interested in science because I've introduced it to him early and he likes seeing where things go. And I think the more kids we can do that to, we can spark that. And the reality is we're never going to we can't compete because honestly, it's not always about the money. You can ask the 230 people that work with me, they don't work there because they make a lot of money. Okay? The people who left to go for for different aspirations, they didn't have the same drive that maybe some of us had in terms of keeping us, making less, working more hours, but they're all necessary because the whole system is going to need everybody as part of this. The last two pieces are politicization. I'm not going to go into that, but we all know what it did. It's the third rail. But communication, and I want to give a shout out to CDC and their LOCKS calls, the Laboratory Outreach Communication System, which is so critical once we finally got our feet on the ground to communicate routinely to all laboratories and the laboratory system. And helping us scientists learn how not to geek speak, but to communicate what needed to be said, how it needed to be said, and where people were. And so all of that together are the challenges we need to take into the next step. Because we had our technological challenges in response to COVID and Mpox, but we had a whole bunch of anthropological challenges that we need to address for the future. And finally, a little fun at the end here. The picture on the left is actually a sample that came to my lab. It was in the beginning when the private labs had to have five samples validated before they could report out. And this is what we got. A package that said this was positive for COVID-19. It didn't have anything else, who to call back with the result or anything like that. And then on the top right was when we ran out of everything again, I'd like to share that a little ingenuity on my procurement team, and I had a picture of her earlier, we just happened to Google flock swabs and find out that Walmart sold them. And Walmart had a stock because nobody thought to go to Walmart for flock swabs. And so we were able to buy 10 cases of flock swabs when nobody else could find them from Walmart. And that's the end. Thank you very much.
Scott, thank you very much. All right, Joe, and we can't talk about swabs. You just made my hands sweat when you did that one. Oh. Joe,
thank you.
welcome.
I'm going to stay here to do this. I did not make up slides because I wasn't quite sure what my role in contributing to this group was going to be. So I've been listening very carefully. How many people in the audience are veterinarians? Yeah, I kind of get that a lot for where I go. So I figured I would take this in a slightly different direction. Instead of simply talking about the laboratory network, National Animal Health Lab Network, or what the things were there, I try and link this to many of the comments I've heard today so far, and I appreciate yours about including the agricultural components and so on. But I think from the agricultural perspective, there needs to be a mindset change in how laboratories are approached. I'm going to talk more about the software component, and I don't mean the LRN stuff. I mean the human interaction between the laboratory personnel and where their thinking needs to be, rather than the data and communicating that data other than by fax and so on. So part of where I wanted to go is we're talking about public health emergencies. When does that emergency start? It starts with that first case of Marburg, maybe, in the United States. But does it start with a case of inhalation anthrax in North Dakota? Probably inhalation anthrax, right? In fact, I worked at the White House when we worked up a BOTA biological threat thing, and that should have been reported immediately, except it was never reported. It came out much later that there was an inhalation case. somebody who happened to be infected from soil in North Dakota that was left over from the great westward movement where cattle would die and just got left by the side of the road, but it never got reported. So even though it was within the laboratory system that it was being diagnosed, but there was no sort of hue and outcry that something needed to be done, that perhaps a greater net of diagnostics for respiratory illness should have occurred. So some of this stuff is more of that soft science of how the laboratories need to work with each other and think not just in terms of a hard and fast protocol, but in the light of the reality of the world, what needs to happen other than just following the protocol. I am currently the Executive Vice President of the National Association of Federal Veterinarians. It's an organization that represents the 3,000 veterinarians that work in 22 different federal agencies across the U.S. and around the world. Prior to that, I worked for USDA in their Animal and Plant Health Inspection Lab, and I was the Director of Emergency Programs. While Director of Emergency Programs, I got to deal with things like avian influenza and pandemic preparedness, bovine spongiform encephalopathy, monkeypox, no, not mpox, monkeypox from 2003, where it truly was animal origin that spilled over into humans. West Nile virus, in fact, the reason I'm here is Tracy McNamara was asked to speak, and Tracy recommended, she had a heavy teaching load and couldn't make it. So she suggested that I come in her stead. So we'll talk a little bit about her situation with West Nile and working with laboratories. The development of the NALN Laboratories, National Animal Health Lab Network. And I also worked at the White House National Security Council, their Interagency Coordination and Policy Committee, where I was also generally the only veterinarian in the room. And as topics come up, I would just raise my hand and somebody would say, now what about the animals in this situation? Where does that come in? So, for example, everyone's been talking about COVID, and you've done a lot of testing for COVID, and you've talked a lot about how CMS covers COVID testing and how that evolved and so on. The only problem is white-tailed deer aren't covered by CMS. So who pays for their testing? The thousands of those tests across the country, there are now deer in just about every state that have tested positive for COVID. And what is the long-term implications of that in terms of the mutation of that organism? Who's going to continue to do that testing? Where is the money for that going to come from? I would argue that that is a public health benefit to continue to do that testing. Yet those white-tailed deer, in most cases, aren't owned by anybody. In a few cases, they are farmed-raised deer, and it may be in their benefit to test those. But otherwise, it's wildlife agencies that don't get any money to do COVID testing that are responsible for monitoring the extent of COVID in the wildlife population. So we need to be thinking in terms of how our lab network systems are going to work together, where the benefit is accrued to one side of the equation, the human health side. But the only thing that occurs on the animal health side is negative. I mean, states make a lot of money off of wildlife hunting licenses and maintaining healthy wildlife populations for hunting. As soon as you start identifying COVID-positive deer, what happens to hunting and eating of venison? It starts to drop off. So there's only a negative incentive to do testing on the animal health side, yet there's a positive public health accrual on the other side of that. The other thing I think we need to keep in mind from this public health emergency piece is that the emergence of zoonotic diseases, it's been estimated 70 to 80% of newly emerging infectious diseases are arising from animal populations. So if we were able to do the testing in the animal population and perhaps identify where those may be emerging from, we might be able to do a better job of being prepared on the human health side for when or if a spillover occurs. We talked about anthrax a little bit. Some of the connections that perhaps could have been there better in this situation, but we'd heard about a man in Florida that had inhalation anthrax. One of the investigators' questions to me in Washington, because I was director of emergency programs, was, has there ever been a case of anthrax in animals in North Carolina? Because the man that died of anthrax was in North Carolina hiking in the mountains prior to that event. Believe it or not, I checked with the North Carolina laboratories. There's never been a case of anthrax in animals reported. So it certainly eliminated the possibility of a natural infection in that case if he'd been in an area where we didn't know that anthrax ever existed. So linkages between the networks there could have been helpful to identify that a little more quickly than like a week after the event occurred. Pandemic influenza, 2009 H1N1. One of the other challenges, just to make you aware of, is H1N1 is a very common virus in pigs. It's probably the most common influenza virus in pigs. Therefore, CDC initially began calling the 2001 H1N1 pandemic swine flu, which caused Egypt to kill a whole bunch of pigs because they didn't want pigs spreading this disease. It was human-to-human transmission. Pigs were not involved in the 2009 H1N1 pandemic. The markets for swine dropped dramatically when it started to be called swine flu, because the natural implication would be, if it's swine flu, it must come from swine. So there's a lot of that communication that needs to happen. We were able to get a different naming convention for that, where it was 2009 H1N1. But one of the things that happened that go to the lab testing capacity issue is we've heard a lot about overwhelming number of samples that needed to be tested. When influenza, the pandemic influenza, first entered the United States, I believe it was probably out of Mexico and into the southeast area, and Texas in particular. Texas started testing every respiratory illness, every ILI, as a potential influenza, and started doing this H1N1 testing. They were so overwhelmed that they reached out to their emergency management community and put in a request for assistance in laboratory diagnostic testing. And that request went through their governor, it went up to FEMA, and from FEMA it came out to the multiple emergency support functions. One of them is ESF 11, which is agriculture. And when we got that request, we sort of said, you know, there's an animal health lab across the street from your public health lab with people who are trained, not ACL, what's the acronym? CLIA, thank you. They're not CLIA approved, but they're running the same tests for influenza viruses. Is there something that you guys can do to work together to use that as your surge capacity? Well, that had never been thought of before, but certainly in COVID, there's been a greater number of laboratories, and you had mentioned that there are more of the non labs that are CLIA certified now. But back then, there was not a connection between those laboratories that coexisted, you know, in the same sort of community, but not doing the same sort of testing. The monkeypox situation was another case of the laboratories, this time working extremely well together. CDC was able to reach out to USDA and said, hey, we've got these cases of monkeypox, and they seem to be associated with Gambian rats. Well, why reach out to agriculture with Gambian rats? Not a food source in the United States, so it wasn't a food safety issue. But it turns out that a component of USDA regulates exotic animals in pet stores. And we regulated Gambian rats in pet stores and also prairie dogs in pet stores. Who knew when you put prairie dogs and Gambian rats together that there was an easy transmission between them? So people who had prairie dogs were getting infected with monkeypox because they were being the disease was being transmitted in the pet shops. But CDC was doing all the monkeypox testing because, again, the NVSL laboratory wasn't able to handle human samples, and since this was a potential human pathogen, it all had to go to CDC, so they became overwhelmed with doing the testing. But a positive situation out of that avian influenza situation is CDC's influenza unit became very concerned about whether or not viruses in swine were mutating sufficiently to become the next pandemic. So what CDC did was approach the veterinary laboratory and asked if we could increase the number of influenza tests we were doing in swine, doing complete sequencing of those and giving them to CDC so they could consider where antigenic drift was happening and where human vaccines needed to be generated. USDA didn't have the money to do all those extra tests. Influenza in swine is simply managed between the herd owner and their private veterinarian. It's not a regulatory disease. So in order to do all those testing, we needed funding to do it. CDC transferred $1 million to USDA to be able to do that testing. I think an outstanding use of those resources, that if CDC tried to get those samples themselves and test those samples themselves, it would have put a big burden on their lab system. Yet they had the funding to be able to pay for somebody else to do it. So where lab networks can work together like that, we get some really positive outcomes. And then I was just going to leave you, the Japanese bee encephalitis in New York City. Remember that one? Well, we had a veterinary pathologist at the Bronx Zoo by the name of Tracy McNamara who was seeing birds dropping out of trees in New York City. And being the pathologist she was, she looked at them and it didn't appear to be anything that was sort of naturally occurring in that area. Whatever she was seeing seemed unusual to her and was some sort of encephalopathy. And she tried getting CDC to run those tests. CDC, maybe rightfully so, said, sorry, we don't test blackbirds. And no, we're dealing with this Japanese bee encephalitis outbreak right now. We're not going to be testing birds for you. So she reached out to USDA and she reached out to USAMRIID, some people that she knew there. And she said, let's report this as a foreign animal disease. So as a foreign animal disease, we could collect those samples. We could test those in our National Veterinary Services Laboratory. They did. They looked at it under an electron microscope and said, this isn't anything that we have seen before. This is likely a virus that CDC needs to look at. They sent the sample to Denver, or not to Denver, but to Colorado, where they did the testing and found that, yes, in fact, these birds were dying of West Nile virus. But there was this separation between the laboratories that said, we don't test these birds, regardless of what you may be seeing clinically, that says this could very well be the cause of your Japanese bee encephalitis outbreak. So I wanted to just end with that this interoperability you discussed before and brought up needs to go beyond the interoperability of the human laboratory network systems, but to include the agricultural network systems, and also to not just worry about those hard sciences where the data fields are compatible and so on, but work on the human soft sciences where folks need to be aware, like somebody said, you don't hand business cards out in the beginning of an emergency, but you need to know those people well enough in advance, know what their skill sets are, and know when you might need to call them in to assist you with your emergency.
Joe, thank you very much. Do we have Yua on the line?
Yes, good afternoon, everyone. I'm Eva King. I'm a Chief Program Officer with APHL, but until last year, I was a Laboratory Director at the State Health Laboratories in Rhode Island. So in my presentation, I will share my experience from likely both of these walks of life. Just, and hopefully you can see my screen properly. So I'm going to concentrate and perhaps bring us back slightly to the topics that Dr. Middleberg was covering, but perhaps with a slightly different public health laboratory focus. So I'd like to first kind of quantify and define perhaps what I'm going to talk about. And it's public health emergencies that involve chemical agents. When this topic comes up, I think frequently people think about chemical spills or release into the environment that results in human exposures down the road. And obviously the most recent example that was already mentioned was the release of vinyl chloride and other VOCs, and then eventually their combustion products following a train derailment in East Palestine, Ohio. Those are actual photos from that incident. But we also need to keep in mind situations where it's more of a slow and perhaps unnoticed release of certain chemicals like PFAS, where exposures over months, sometimes years, follow contamination of drinking water supplies. That has been the case in Minnesota, New Hampshire, New York, and many other states, including Rhode Island. Those situations are not necessarily noticed immediately, those chronic exposures. I think bring us back to our definition. What do we consider to be emergencies, whether this is really an emergency or a slowly brewing public health problem. But I'd like to also focus on a slightly different set of problems that involve ingestion of products that contain toxic substances that result in adverse health effects, usually acute adverse health effects. So for that, I'm going to use the case of EVALI, or multiple cases of EVALI. If you recall, in the summer and fall of 2019, public health authorities noticed that there were cases of e-cigarette or vaping associated acute lung injury. And now that was really a very much a puzzle that needed to be solved. And I will spend another slide on that very example. As another example of those kind of public health emergencies that may result from a contaminated product, if not necessarily a legal product or pharmaceutical, was a cluster of overdoses caused by acetylfentanyl in Rhode Island in 2013. The reason I'm bringing up this particular incident was because it was actually before fentanyl and fentanyl analogs became a household name. So at the time, we were really not thinking that fentanyl was something that was circulating in a community of drug users. The laboratory capacity was definitely, and capability was definitely challenged at that time for us to figure out what was the implicated agent. And that acetylfentanyl still circulates in the drug supply in Rhode Island and other states and is routinely being detected. So what are the laboratory testing needs in a chemical emergency? Regardless of how individuals might get exposed to those toxic chemicals, there's usually some need for either environmental testing, environmental monitoring, where laboratories are needed to test environmental samples from the area of release. So we're thinking ambient air, soil, water, drinking water sources, of course, are something that we are most concerned about. But all of those, there could be thousands and thousands of environmental samples that would need to be tested to characterize the spread of those chemicals that were released. But in this other context that are also where chemicals are implicated, we would be really needing product testing. So we're talking about, whether it's food items, pharmaceuticals, or other illegal drugs, or consumer products that might contaminate or be directly ingested and cause health effects. And last but not least is what we in public health tend to call biomonitoring, but it's really clinical toxicology and very much in the wheelhouse of Dr. Middleberg as well. Our laboratory to test clinical samples, clinical human samples, I should add, to determine if individuals have been exposed to the chemical in question and to what extent. And of course, there's a whole host of questions that come up, that some of them were already covered, about oversight, about detection limits, about what is a normal level in those situations, especially for chemicals that have not been studied for decades in terms of their toxicity. So I'd like to dedicate this slide to talking about something I personally consider a success story in emergency response that involved multiple types of laboratories and involved vaping or e-cigarette use, and was also especially challenging because even though it was associated with vaping and e-cigarette use, it was really very unclear until laboratories were able to help solve that problem, what was actually causing the health issues. So as a reminder, those were cases of lung injury that were correlated with the use of e-cigarettes and vaping. And as you may know, the mixtures that are involved, the chemical mixtures that are utilized in e-cigarettes are fairly complex and of course not particularly standardized. So there was a host of possible additives or contaminants that might have been causing those particular cases of injury. What I consider a success story in this particular situation, in that there was a very coordinated federal agencies' response to these cases of lung injury. I feel there was also very clear communication to states on what needed to be done, what samples to collect, how they needed to be collected, where they could be stored until methodology was developed for this unusual type of sample, and how to transport to those designated laboratories. So many LRNC and FERN laboratories, those are the networks that have been mentioned earlier today, and other state laboratories facilitated that product collection and storage. So the product were the vaping cartridges or e-cigarettes. Many very complex product testing tests were performed at multiple state and federal laboratories to really solve that problem, to figure out what was the causative, or at least most likely causative agent. There was also clinical testing performed. So CDC and CEH laboratories performed this clinical testing on lung washing, lavage, and the FDA Forensic Chemistry Center laboratories led product testing. So the likely chemical cause of that injury, which was determined to be vitamin E acetate, was actually identified through laboratory testing and was first found by the Wadsworth Center but eventually confirmed, or at least very strongly implicated by testing of these clinical samples. So when this particular chemical was found in both clinical samples and environmental product samples, that really show that this was the most likely causative agent. Again, I cannot overstate how complicated that type of testing was. This is not an instance where the testing methodology is ready to go, or this is something that's tested on a regular basis. So switching back to overall comments on what works well in chemical and environmental emergencies from the laboratory standpoint, I do think that it's a huge plus that the CDC-led LRNC laboratories are established in public health laboratories in all states. As we've heard, they have different scope and capacities, but they do exist in all 50 states. Their testing methodology is by design high throughput. All of those methods are for priority agents are designed to be run in thousands. But at the same time, since those emergencies do not occur every single day, there is a dual peacetime use of LRNC laboratories for biomonitoring of chronic environmental exposures or characterization of drug overdoses. And those are uses that we see every single day. The Fern laboratories are also established in some public health laboratories for testing of chemicals. And I'm indicating some public health laboratories because most have Fern laboratories for microbiology testing, but not necessarily for chemistry testing of contaminated foods. And of course, many public health laboratories have extensive drinking water testing capabilities, as do many utility laboratories, drinking water treatment plant laboratories. And commercial laboratories have extensive environmental testing capabilities. There's been little talk about that aspect of response, but commercial laboratories, or really laboratories that test matrices, samples other than drinking water, have to be prepared for those type of emergencies as well. And some emergency response resources are available through the EPA Water Laboratory Alliance. Of course, there is a large number of ongoing concerns and gaps, and I will spend the last two of my slides on enumerating some of those concerns. So as has been noted previously, the laboratories that test for chemical contaminants are actually regulated by many, many different agencies. And that includes federal and state agencies. And it really very much depends whether you're looking for a chemical in an environmental sample, whether you're looking for a chemical in food, or the exact same chemical in a clinical samples. You would be subject to very, very different regulations. It might not be a concern on its own, but it does result in confusion and inability to use laboratories in an emergency immediately when they're not authorized, when they're not accredited for testing in that specific matrix type. This concern exists less for pathogen detection, but it certainly exists for chemical testing. And the one concern that we really need to emphasize here is there's really no coordinated or funded emergency response network for governmental laboratories involved in environmental testing. EPA does maintain ERLN and Water Laboratory Alliance, but those networks are really, the word that comes to mind is dormant. They are not funded. There's no funding for laboratories from the environmental agency. They very underutilized and not routinely activated for environmental emergencies. And on a larger scale, the concern that I'd like to bring up here is that the number of potentially toxic chemicals in multiple sample types makes it difficult to maintain sufficient laboratory capacity for targeted testing. So what I mean by targeted testing, those are testing methodologies that look for specific chemicals and utilize reference materials for that specific chemical. Dr. Middleberg has mentioned that concern as well. We cannot, it's simply not possible for laboratories to be prepared for every single chemical out there. So that makes a preparation for emergencies a very tall order that needs to be thought through in a kind of a different way. And that different way that we do have is something called non-targeted analysis or non-targeted testing, where we're using new technologies such as high-resolution mass spectrometry to figure out what chemical might be involved in a sample without necessarily having the reference materials and chemical standards available for them. This might be very much needed in the early stages of a response where it's not known what chemical is involved. So in many environmental emergencies, we know what has been spilled. So it kind of targets and focuses our testing efforts. But that's not necessarily going to be the case in all situations. And example of a valley actually highlights how difficult it might be and how just-in-time method development might be needed for this type of testing. And this is actually my last slide, but we would be remiss if we would not point out something APHL has been talking about for multiple years, and others, of course, have also done so. Even in a very small scale incident that involves radionuclides or radiochemicals, radioactive chemicals, we would overwhelm the laboratory capacity in the US very, very quickly. This has already been demonstrated, and I'm using an example from 2019 where there was an incident involving a blood irradiation source at a Seattle hospital that was breached and released radioactivity. The laboratory resources involved in dealing with this very small incident consumed public health laboratory resources in Washington for many months, and exemplifies the extent of this problem. So there's a critical shortage of radiochemistry laboratories throughout the nation, as well as trained laboratory scientists. That there is very little in terms of a pipeline of new scientists in radiochemistry, and of course it's a niche need that is not really being fulfilled at the moment. And once again, that limited national capacity in detecting radionuclides, this is in both environmental samples, food, and it's almost non-existent with the exception of the CDC laboratories in clinical samples in what's called radio bioassays. And as Scott Becker mentioned this morning, there is really no LRNR. There is no network of laboratories that would be able to respond to emergencies involving radionuclides. And thank you very much for your time.
Ooh, thanks very much. All right, we're going to move on to the next part of our session, which is some rapid fire questions for our panelists, and then we'll move to audience questions for the remainder of the time. Christina, what role do the public health labs see for private sectors in non-pandemic related events?
So I think that we really need to rethink about our laboratory system and Although we're not talking about COVID-19, I think the use of clinical and academic labs, we had great partnerships. We still have those partnerships. They should be continued and fostered for future events. And I think we also need to think about other types of laboratories that we don't normally think about. You talked about our veterinary diagnostic laboratories, food testing labs. There's a large number of partners that I think could contribute to emergency response.
Christina, thank you. Rob, are emergencies defined by the number of individuals affected or by need?
It's a great question.
Actually, can you repeat the question? Oh, I'm so sorry. See, there went my training down the hill. Are emergencies defined by the number of individuals affected or by need?
In my world, it's by need. It's not by number. I know there's probably some differing opinions on that, but I think I gave examples where need, people bleeding to death left and right, that's a need. Not thousands, not millions of samples, but still a need. So I would define it by need more so than by numbers.
Thank you, Rob. Scott, who should be in charge of logistics in an emergency, or who oversees the event, the selection of labs, and when bioanalytical testing should stop?
Are you the person who assigned me COVID and Mpox in 10 minutes? I think there were 3 questions there. So I don't think I think we need to bring in, and I think Washington might have done this working with Amazon. There are logistics companies, experts. That's not me. That specialize in this, and during the beginning stages of the pandemic, when everybody wanted to help, there were groups that came out. There were universities who study packaging, and universities programs who looked at sort of logistics had offered. So I think that, I don't know who it is. It's just not the laboratories themselves or the laboratorians, but partners that we need to identify on who can. I mean, like I said, Walmart had swabs, so clearly there's something there.
Thank you, Scott.
I'm out. Okay, good.
Yeah. And remember, we can't talk about swabs. Oh. All right. Christina, pivoting back to you, should laboratories that do human biomonitoring be accredited by an appropriate agency such as CLIA?
I would have to say yes. I think that's really important for high-quality testing.
Thank you, Christina. All right, we have time for a couple of questions from the audience.
Jeanette Warner from Emory University. Before I came to Emory, I was at CDC in the infectious disease pathology branch, and I must say thank you to our veterinarian friends that provided a lot of specimens so that we could do validated testing for anthrax, the immunohistochemical assays that we use for anthrax. And here comes the more interesting and question that I have. If I think about the anthrax bioterrorism attack, we ended up going to Florida and Connecticut to do autopsies as the CDC team. And we worked, because I didn't have a license in Florida. We had all the 3 of pathologists that were working there had licenses in Georgia, but not in Florida or Connecticut or New York. So we had to work with the forensics departments, with the MEs in the different locations. And I can tell you one thing. I think we're leaving out a huge group of people that will be involved in the next big event. And it could end up being fentanyl. Forensics already discovered the first Burkholderia pseudomallei in Georgia. So we need to incorporate the medical examiners, the forensic group into these discussions. And I worry a lot because with all these hospitals that are going bust, all these clinics that are they're disappearing with what's happening with our healthcare system, there's going to be a lot of people dying at home, single people, okay, 1Cs and 2Cs here and there. So one case is enough, 1Cs and 2Cs, and they could be our next index case of whatever you want to call it, disease X. So to me, we're leaving out a large group of people that should be involved in some of these discussions.
Thank you. Scott.
So in North Carolina, the chief medical examiner is in the Division of Public Health and co-located with the state lab. My chief medical examiner is in the same building as me. We do not use the relationship as much as we should. They are struggling for reasons kind of related to what you're saying, is that people don't want to be medical examiners around the state. It's same thing, fees and et cetera. So our legislature right now is debating legislation to support the medical examiner system of North Carolina. But it had benefit during the vaping in 2019, where they were identifying young people who were dying with lung injury, and it afforded an opportunity for collaboration with the public health lab. So I agree 100%, and it's something that our chief medical examiner and I have talked about for future is supporting. Right now, we have a supportive role with their toxicology lab, with similar technologies in our chemical terrorism and threat lab, so we can provide a supportive role, but looking at opportunities for early detection in decedents.
Thank you, Scott. Yes, please.
So we're pretty fortunate where I am. Our lab is both a forensic toxicology and clinical toxicology laboratory. So we do about half of the post-mortem forensic toxicology work in the United States for cities like Denver and Chicago and Detroit, and I can go on, entire states. And we are able to take advantage of that to do population studies on the samples that we have. Everything gets de-identified, but we're able to go and do population studies. So you are correct that utilizing medical examiners for at least the kind of work that we do is very advantageous.
Thank you, Rob. Next question, please.
Hi, everyone. Sam Scarpino, Northeastern University. One of the things that many public health labs globally do, and that some labs that were not public health labs, for example, at Northeastern did during the pandemic, is to test at a high enough per capita volume to control the spread of an infectious disease. So not necessarily surveillance testing and not sort of complex testing for novel pathogens, but actually a high throughput test targeted towards control. And that wasn't anything that came up in this panel, and it was sort of implied in Scott's comment about the population, but I'm curious, do we feel as though that's under the purview of public health labs? Is that beyond the scope of what we should expect given the vast array of pathogens and in the case of chemical contaminants that are required, and so you just can't have high throughput and high complexity? Curious on thoughts about control as compared to surveillance or diagnostics.
So I guess I would say that normally many public health labs get involved in the early part of that response. So I guess, and it's interesting, it depends on how high throughput you're talking. In certain parts of the country, for example, in Iowa, the Iowa State Public Health Laboratory did most of the testing because they didn't have the availability of, say, all of the labs and academic institutions we have in New York. So I guess I would have to say, it kind of depends, but I can really see the use of academic institutions in future responses contributing for many different areas, including, surveillance as well.
Thank you, Christina. All right, last three questions. Go ahead, please.
Thank you. I'm Corey Meyer, Griffin Scientific. So this is a follow-up question for Scott specifically regarding the COVID-19 testing task force that you mentioned at the state level. So one of the things that I've heard commonly from the public health lab community is that it's difficult to know the landscape of potential partners because the private sector is sprawling, there's turnover, it's business. So I'm curious if you can comment on, within that task force, if you felt like you had a comprehensive understanding, how you developed that understanding, and how you thought through how to allocate resources, and would welcome comments from Christina and Eva as well. Thank you.
Great, thanks. And I appreciate the opportunity to expand on it was the COVID testing surge work group. I'll be, be clear about it. And unfortunately, I think Anita left, but we actually had a member of the head of the Board of Pharmacy actually was also on the work group, because we identified obviously pharmacies early, and part of the ICAT program was the expansion. So we had a wide array of partners. We had members from the major commercial labs, so LabCorp, Quest, and a local lab in North Carolina, Mako Medical Labs. We had our major hospital systems, Vidant Medical Center, UNC Duke, Atrium. We also had our local health departments represented, at least some of them, because they were the ground truth of like what kind of testing would help and what volumes and where. As I mentioned, pharmacy. We had primary care, and we were particularly aware of the need to address the massive burden on historically marginalized populations. So we were very deliberate about attending to our rural populations, our tribal populations, as well as physicians and community leaders. For those who would be trusted partners of the messaging that any kind of subject matter experts would generate out of that work group. So I think it was a great group. You know, prior to this group, the state lab in North Carolina had, as part of our FEP, Public Health Emergency Preparedness work, what we call Lab Response Forum, which was a bunch of lab directors getting around and with the EPIs and just geek speak. But the work group helped us realize that we need that diverse partnership to meet routinely. So while we are going to resume the lab forum, where it's just lab and epi talking routinely, we're going to maintain that partnership. We won't meet as frequently, because at some points we were meeting weekly. And you asked about resources, there were none. It was people were like, I want to help. And they had their name on the governor's task work group, and it was important. And eventually they said, so-and-so is going to now pop in for me, but their organization was represented, which was the important part of that.
Thank you, Scott. Next to the last question.
Thanks. I'll make it a statement so you don't have to feel obliged to respond, since we're short on time. But Scott, I wanted to build a little on what you talked about in terms of politicization, which we don't maybe want to talk about, but we've talked a little about having a playbook for improvement, and there's clearly a playbook for folks who would like the public health system to be less efficient and effective, writ large, and testing and tracking and reporting of disease to be less effective and accurate. So I think it's worth at least having those things in the book today. These are clearly factors that influence the performance. And within politicization, there are probably a few things that we should be thinking about. One is the sort of libertarian ideological objections to the big government collecting data on me and having that accessible, especially then that bleeds into the sort of, you're in the pocket of big pharma and the big lab, if such a thing exists. And that's, sort of driving that relationship between private-public partnerships that we think of as being positive. Not everyone sees them as positive. They see them as corrupting. So we have to be willing to talk about that in some way. And then the other couple things are around trust in the healthcare system. People who don't show up to doctors, to hospitals, to clinics because they mistrust us are a big weak point in the testing infrastructure for all kinds of things. We have a very large number of people still who are uninsured in the United States, and that number is about to go up fairly dramatically in the next few months as the Medicaid changes take place. A wise terrorist would start their bioterror event in an immigrant uninsured community, and you can expect that such an event would spread out into the larger community probably before the first testing happened. So I think all of those things deserve to be on the docket, even if they're not the primary focus. We're talking a lot about sort of the technical solutions to this, but some of what we're talking about here are complex sociological, adaptive type challenges.
Thank you. Last question, please.
Hi, my name is Andrew Scott. I work for DHS in the Office of Health Security. I'm a health physicist. So my question is directed at Eva regarding the radiological slide that you had at the end. What are your thoughts regarding the use of occupational health and safety monitoring labs that do bioassay or specifically bioassay and engaging that capability and capacity in the event of a radiological emergency and potentially other emergencies? So not diagnosis and treatment, but for the purpose of occupational health and safety monitoring. So they're running human samples, but not CLIA certified. Thank you.
Right. So absolutely, that is a resource that we should consider and figure out a way to engage. Those laboratories do have the capacity to do occupational screening and surveillance. I do not actually have data on what the capacity is, which I think in itself is telling that we don't know precisely how much of that capacity exists, but that is definitely something that could help. The CLIA angle, obviously, here is of concern because we do expect laboratories testing humans for the purpose of characterizing their health states and provide and to provide treatment. Those laboratories do need to be CLIA certified. So that is the one snag that would prevent us from immediate accessing of these laboratories for the purpose of emergency response and figuring out how many people have been exposed.
Ooh, thank you. Everyone, we went a few minutes over. Panelists, thank you very much. Audience, thanks for your engagement. We can go on break now. Please return to your seats at 3 p.m. Thank you.
So thank you for joining us for the late afternoon session. My name is Andrew Scott. I am from the DHS Office of Health Security. My title is the Senior Radiological Nuclear Health Advisor. However, I'm here in the capacity of the Program Manager for Integrated Consortium of Laboratory Networks. I'm going to be moderating our panel today. Each of our panelists has a few brief comments, and then we'll go into a question and answer period. So to my right, I have Ren Salerno, who's the Director of the Division of Laboratory Systems in the Office of Laboratory Science and Safety. And he's with the U.S. Centers for Disease Control and Prevention. And we have Beth Marlowe, who's a Scientific Director and Head R&D for Infectious Disease and Immunology at Quest Diagnostic Infectious Disease. We have Matthew Binnicker, who is the Director of Clinical Virology in the Division of Clinical Microbiology of the Department of Laboratory Medicine and Pathology at the Mayo Clinic. He is representing the American Society of Microbiology. We also have remotely Dan Harms, the Clinical Laboratory Officer and Associate Director for the Center for Clinical Laboratory Medicine at the Armed Forces Institute of Pathology. He also runs the Defense Laboratory Network. And then we have John Griggs, who is the Lab Director of the National Analytical Radiation and Environmental Laboratory, or NAREL, at the U.S. Environmental Protection Agency. So, Ren, I turn it over to you.
All right. Thank you, Andrew. Thank you, National Academies. Thanks to those of you who thought that I could contribute something here. What I'd like to just spend a couple of minutes on is some work that we've been doing at CDC based on a lot of input from many of you and many others to try to address what we're calling National Laboratory System Response. This is a work in progress. Obviously, we've spent a lot of time over the last few years responding and learning from our mistakes as well as our successes. So I'm not going to talk too much about the past unless you ask me and force me to. But I am looking for some feedback on what I hope you'll sort of see as a framework or a methodology that we are using at the moment from and the other thing I want to be clear on is that this particular work is focusing on infectious disease response. Okay, so Scott Schoen already talked about this article. I also read it. Thanks to Jay and Jill and Josh. But I pulled a different quote than Scott did earlier. And this one is very specific to CDC, and it says CDC needs to work more closely with everybody, the system, to develop a national roadmap with clearly defined governance, roles, responsibilities for different sectors of the laboratory community at different stages as epidemics evolve. Okay? Wow, yeah, sure, I agree, but it's easy, no offense to the authors, easy, much easier to write this sentence than it is to develop the national roadmap based on what this sentence expects. But that's what we're going to try to do. In fact, that's what we're trying to do now at CDC on the infectious disease front. Okay, so real quickly, I know we've talked a little bit about this. The National Clinical Laboratory System, in terms of performing diagnostic tests, is extensive, right? We've talked about this, and this image is probably, based on today's discussion, already doesn't include some organizations, entities that probably need to be included. But it's CDC and the public health labs, it's clinical labs, commercial labs, all the non-traditional testing sites, including physicians' office laboratories, point-of-care testing, and we obviously saw a lot of drive-through collection and testing during the pandemic. But that's just the testing side, that the performance of diagnostic tests. Okay, that's a complex system just as it looks there. But keep in mind that the system that we've been referring to is much broader than what that previous slide shows of the testers. But these are all those that help enable the testers to perform those tests, right? It's all the federal agencies, right? It is ASPR and BARDA and NIH and FDA and CMS and DOD and all the other ones that I've forgotten to list that enable diagnostic testing during emergency responses. It's the test developers and the instrument and reagent manufacturers. We can't do that testing, especially in a high throughput way, without those manufacturers being on board and part of the system. It's the laboratory organizations, the professional organizations that we rely on extensively to be able to communicate to their huge memberships in a rapid and transparent way, as well as academia and NGOs. So this is a massive, massive system, depending on how you describe it or envision it. Okay, so this is a very, very generic image that I want to show you, but it's kind of the way we're thinking about the testing phases of public health emergency. And I want to make sure you understand, this is an epi curve, but I'm really thinking about it from the point of view of diagnostic testing. And, in our mind, in terms of creating a methodology for thinking about how the system should work across a wide variety of responses, we need to think about sort of moderate level average responses that happen in public health very frequently. You've heard a lot about those, the kinds of responses that don't make the papers, the kinds of things that are happening every single day and that public health laboratories are doing all the time across, not just in infectious disease, but across the spectrum. These are responses that are sort of in that moderate or low level that there are cases, there's testing, there's initial response, and there might be a small amount of surge testing that's required. But for the most part, those responses resolve themselves through the traditional public health system. Then there are larger responses that require not just initial surge, but additional surge. Monkeypox was a great example, right? We decided early on in monkeypox that we needed capacity beyond the public health labs. And then there's obviously extreme, and COVID-19 fits in that category. The other thing I want to talk about here quickly, though, is we've been talking a lot about laboratory response networks, but that surveillance piece on the left-hand side of this, before the curve even goes up, there is a tremendous amount of activity and networks and systems in place just to do surveillance, right? And I want to just list, and I've got a bunch here on this paper, and this is just a scratching the surface. These surveillance systems for not just human disease, but animal disease, water-based disease, food-based disease, right? So we have the NERV system, National Respiratory and Enteric Virus Surveillance System, as well as CaliciNet, right? It's the national lab network that focuses just on norovirus, just looking for norovirus. There's the food systems like FoodNet and PulseNet and NEARS, all systems designed, or laboratory-based systems that are designed to look for potential outbreaks of disease that could cause a public health crisis. They're the animal disease networks, ACOS, Animal Contact Outbreak Surveillance System. They're the water-based disease systems, whether it's CryptoNet or WBDOS, which is the Waterborne Disease and Outbreak Surveillance System, and NWSS, which is one of the newest ones, the National Wastewater Surveillance System. So all these testing systems exist that are operational before the curve even jumps vertically. And so we need to appreciate that there's this complex set of systems that also are in many cases, very independent of one another. And somehow we have to be able to take data and information from that wide variety of surveillance systems and then convert that data and action into diagnostic testing response systems. And so I think that difference between surveillance systems and response systems is really important. But anyway, so we're thinking of these three scenarios of responses. And obviously you see on the right-hand side all the kinds of things that influence the height of these epicurves, right? Available diagnostics, available countermeasures, as well as evolving scientific data obviously will change the case count, change the shape of the curve. Okay, so that's one way of thinking about sort of size of the scenarios. The next we thought is, look, there really are known, from our point of view, thinking about diagnostics in potential response, they're the known diseases and then they're the unknowns. And known diseases, for the most part, we have some degree of diagnostic capacity. It may not be enough. It may be limited to public health labs. It may be a very rudimentary test or a one-at-a-time test, not high-throughput test. But it's a known disease, and we have surveillance systems for those. And then there's the unknown. And those are more problematic, obviously, because we don't have the tests, and we have to create the tests as soon as we begin to identify the disease. And there's hundreds of diseases, right? But from the way we're thinking at the moment, we thought of essentially 5 categories of scenarios that we think shape potential laboratory and testing responses. On the known side, for us, unless you tell us that we're really not thinking this through correctly, the real distinguishing factor is it a respiratory illness or not? Is there airborne transmission? And we think that that's a key driver in impacting how the testing response will occur. Now, there's a third category here that I'll come back to in a second. But on the unknown side, again, we're looking at unknown diseases, whether it's non-respiratory or respiratory. And then this third one under known is we thought we needed to capture, and this was mentioned earlier today, sort of the viral hemorrhagic fever virus type outbreaks that come with a lot of fear in the public, as well as trepidation in the laboratory and testing community, as well as complications around containment and all that kind of stuff. And we may have tests, but it may be really hard for us to do the testing in the way that we think we should. So these are the 5 general scenarios. And then what we'd like to do, this is my last slide, is take a look at a conceptual framework like this, where we look at all these different phases of a response, all these different players in developing, implementing, and executing a diagnostic response, and then essentially fill out this sort of chart 5 different times for each one of those different disease scenarios, the 3 knowns and the 2 unknowns, because we think that across those 5 different scenarios, there may be different roles for each of these players to play in such a system. So that's the approach that we're taking. I'm going to stop there. Welcome to take comments, but we think that if we can create 5 of these charts, that could lead us to a national roadmap for laboratory system response. So thanks.
Thanks, Ren. Please hold your questions until the question and answer period. Next, Beth, you want to make your comments on commercial lab systems? Thank you.
I don't have slides. I just have comments. But thanks, Ren, for that, and thank you for the invitation to be part of this panel today. It's really an important topic. I've had the honor of participating in other panels similar to this, and we start to hear these common themes, right? So what did the pandemic teach us? It taught us to test at scale, right? It taught us we need to think about alternative pathways in terms of engaging patients. It taught us we needed to push innovation forward, and let's be honest, we probably should have been doing that anyways. It taught us we needed to utilize population-level data in real time so we could make accurate decisions. And then it taught us we need to be ready for what's next, which is why we're here today. So if we think about the laboratory ecosystem and we think about the commercial lab that I'm representing today, we play an important role within that ecosystem. And if we think about those roles look, we fill a gap. When there's not a commercially available manufactured assay that can be widely used in practice, we're usually where people go. We provide services to hospitals that may not be an academic hospital, physicians' offices, and even academic hospitals, we help with more esoteric testing. We have a national footprint. We have a national infrastructure. Susan did a really nice job today outlining what is the journey for a patient and that patient sample. We have that infrastructure there. Physicians can order a test. We have logistics to get the test. We have good analytical systems. We know how to report the test. We know how to report those results to the public health. Could we do this all better? Absolutely. But we have that built-in infrastructure. We service 1 in 3 adult Americans. We service 50% of the physicians and hospitals in the United States. You add in LabCorp, Mayo, ARUP, you've got a good footprint. Our strength is our ability to operationalize. So we also have specimen remnants, and leveraging those specimen remnants allows us to do things like surveillance for COVID genotyping, seroprevalence studies. And based on the number of testing we do, we have an amazing data set that can be leveraged. Yes, could we do a better job of leveraging it? Absolutely. We suffer from the same problem as everybody else, right? Your data needs to be clean, it needs to be generalizable, and it needs to be actionable. We're all in the same boat. How do we do that better? That's what we're here to talk about. Those are our strengths. And I will tell you that Quest is committed to a partnership. We actually have an initiative. It's called Public Health 2030. There's 3 arms to it. One of them is response readiness. One is fostering public health partnerships. And then the other arm of it is effective public health data reporting. We're trying to organize ourselves. We were trying to do this before the pandemic started, before my even time at Quest. It really got formulated more during the pandemic. And of course, why fight one pandemic when monkeypox pops up and you can fight too. But we are working towards this. We are thinking about all the same things, because how does an organization that's a commercial laboratory do surveillance when you're not the public health department? But we ourselves want a strategic early warning system. We want to leverage our own data and leverage the folks that are already doing a really good job of surveillance globally. How do we leverage that data and compare it? We're thinking through all of this. I don't have all the solutions today. I've got really smart people that I get to work with every day. I'm hoping to foster additional partnerships coming out of this. But we have hurdles, right? We need to be at the table earlier. We all talked about this, but look, monkeypox was a better experience than COVID, but it wasn't perfect. We got lucky in a lot of ways. We had a vaccine, we had an FDA-approved test, but I'll tell you, that FDA-approved test is not designed for high-throughput testing. Manual extraction with a 4-well assay is really not ideal for high-throughput testing. We were able to develop our own LDT. We were able to leverage what was there. I am very grateful for all the work that was done in New York and the CDC and with the partnership with the FDA, but we can do better. And we were able to develop a higher throughput test. It had redundancy in it, and that's something we didn't talk about. We talked about, people can design tests really fast, but when you sit down and you design a test and you think about a target product profile and what a test should look like, if you think about designing a test really smart earlier on, it helps you downstream. So you add redundancy targets. So if there is a mutation, you're not going to miss something. We picked this up in monkeypox. We picked up a variant out of LA County. We partnered with the LA County Public Health Department, and we published on that. And we let the right agencies know, hey, be on the lookout for it. If we want to talk about home testing, we need to design it so that we make sure that there's appropriate specimen adequacy control, so somebody's not taking an air swab so they can go to work because their livelihood depends on a negative sample. These are all things that we need to be thinking about as we put through it, but we should be doing it much earlier in the process, not when we're trying to build a plane while we're flying it, and not while we're still trying to get paperwork in place. That paperwork should be in there. We should all be pre-qualified. We should be rowing in the same direction, because there's 4 phases to a pandemic, right? There's what's coming, there's the chaos, there's the ramp up, and then there's stability. We want to shorten or eliminate that chaos so that we can ramp up very quickly, right? I liken it to a bacterial growth curve. I'm a microbiologist. That's how I think. Funding. We keep talking about funding. We need to be able to sustain an infrastructure, and we need to be able to have reimbursement. Thank you, Susan, for all the work you guys are doing with reimbursement, because it's so critical. We can't do the testing if we don't get paid for it. It's just that simple. And then workforce. Scott, thank you for bringing up everything you brought out about workforce. Workforce shortages are so critical in healthcare, in the lab. And if you live in a state like in California, like I do, the licensing needs to be updated. It shouldn't be a barrier because I have legislation from the 70s on the books in my state. I'm probably not going to be popular for saying it, but it is what it is. So, at the end of the day, it's really about, how do we combine our strengths? How do we fit into this ecosystem? I always use the Steve Jobs analogy. Steve Jobs, if he sat in his little corner in Silicon Valley, would have never thought about the iPod or Pixar or any of these other things. But if we can look across systems and really build on those strengths, we can do better. And it requires a different mindset. We keep talking about emergencies, and I get it, that's why we're here, but I think of it much bigger in terms of our healthcare system, because I think we can move the needle on healthcare by putting some of this infrastructure in place, by getting better access to testing, by having better follow-up, and having better data. Look, we live in a data economy, right? Data speaks. We should be doing this anyways. And so I think collectively we can do it. We will get there. It's just going to take a little work together. Thank you.
Thanks, Beth. Matt, your comments from ASM perspective?
Yeah, thanks, Andy. So I am representing the American Society for Microbiology today. Tomorrow I'll represent my more personal views and Mayo Clinic's views. But I really wanted to capture ASM's sentiments, which represents hospital labs, clinical labs, commercial laboratories. So those labs that are performing patient testing on a day-to-day basis. I wanted to capture the sentiments of those groups really with 4 core issues that represent the role of clinical laboratories and the capabilities of clinical laboratories in responding and preparing for outbreaks and pandemics. The first core issue is that ASM, and this is actually a personal belief as well, that the clinical laboratories represent the tip of the spear in a response to an outbreak and pandemic because we are closest to the patients who are presenting for care. By including clinical laboratories, whether those be in hospitals, small clinics, or larger reference laboratories, we're able to perform that testing and get the answer to the caring physician and the patient in the most rapid time frame possible. So again, encompassing the clinical lab in the response and preparedness is essential. The second core issue, as it's been brought up in a number of times today, is currently CLIA regulations indicate that testing needs to be performed in a CLIA laboratory for diagnosis and management of patient care. There's been a lot of discussion over the last 3 years about whether we should expand testing in a response environment outside of CLIA laboratories, and I think that'd be a great point for discussion. I think if we get it right in terms of building up that adaptable infrastructure, the need to expand beyond CLIA laboratories becomes less and less the more we get the system built correctly. In COVID, we were having to have those conversations because the CLIA laboratories were in chaos mode. And so we were having to pull staff and equipment and resources from non-CLIA settings. The third issue that I wanted to raise is that most of the ASM members, the clinical laboratories in hospitals, small clinics, don't have the capability to rapidly develop a test for a novel agent, especially that's going to have to be submitted for emergency use authorization review. My lab decided on February 17th to do that. I put together a team of 15 people, and it took that team of 15 people 3 weeks of working night and day to get a test up and running for COVID-19. I have colleagues around the country who are doing the exact same thing when my hope would have been that we would have had access to a test and we could have all been testing during that period of time rather than working so hard to solve the same problem. Now, if we look across the country at those small hospital and clinical labs, they don't have that capability. So what are they doing? They're waiting. They're waiting for a commercial option to come online that they can purchase and bring into their lab. And then when those commercial options come online, it's Hunger Games for laboratories in terms of, can we get the equipment to do the test? Can we get the reagents to do the test? And so that is an issue we've got to grapple with, is expanding out that testing capability, bringing more of those frontline testing laboratories online rather than having just to sit and wait. The fourth issue, and it's been talked about over and over and over again, is the dependency on supply chain. And I don't have a perfect answer for how that's going to be resolved in the future, other than to partner now to develop systems and approaches where we can have redundancy is important, but bringing in our industry partners who are developing the needed equipment, reagents, collection supplies, so that they can be part of that equation of getting the necessary supplies and components to testing laboratories in a response setting is going to be absolutely essential for a better response in the future.
Thanks, Matt. Now we're going to go to one of our virtual presenters, Dan Harms. He's representing the Defense Laboratory Network, and I'm hoping he'll broaden our aperture a little bit to the whole threat space of CBRN. Dan, are you there? Little technical hiccup.
Yeah, sorry,
Dan?
you lost me all there for a second.
Jan?
Yes, I am now.
Okay.
Can you hear me okay?
You're up. We can hear you.
Okay. Good afternoon. I'm Dan Harms. I'm a laboratory emergency response and regulatory compliance subject matter specialist working within the Center for Laboratory Medicine Services of the Defense Health Agency. Do have to correct the introduction that I had. While I was once in my far past a Colonel U.S. Army working within the Armed Forces Institute of Pathology, that time of my life ended with my retirement from active duty as of 1 October 2009. So I am now a federal GS employee working within the Center for Laboratory Medicine Services of the Defense Health Agency since 2012. The DoD has participated in the DHS-sponsored Integrated Consortium of Laboratory Networks since its establishment, but it wasn't until DoD Instruction 6440 TAC 03 DoD Laboratory Network was published in June 2011 that the DoD officially had a laboratory network that was recognized as one of the ICLN participating laboratory response networks. Under the DoD instruction, I serve as the Executive Secretariat of the DLN and one of the DoD's representatives to the ICLN's Network Coordinating Group, and additionally serve as the DoD Liaison Gatekeeper regarding DoD laboratory participation in the CDC-sponsored Laboratory Response Network. The DLN is, of course, composed of DoD laboratories of all sorts, inclusive of clinical laboratories, public health laboratories, and research laboratories, but also counts among its participants DoD component level members, such as the offices of the Assistant Secretary of Defense for Nuclear, Chemical, and Biological Defense Programs, which oversees the DoD's Chemical, Biological, Radiological, and Nuclear Defense Program, the Assistant Secretary of Defense for Health Affairs, which advises on the clinical healthcare and health surveillance aspects of the CBRN Defense Program, the Assistant Secretary of Defense for Homeland Defense and Hemispheric Affairs, which oversees the DoD's defense support of civil authorities activities, the Joint Staff, the military departments, combatant commands, and select defense agencies, and importantly, response units such as the Marine Corps Chemical Biological Incident Response Force, the CBRF, the National Guard Bureau, which supports the WMD civil support teams, the WMD CSTs program, and the Armed Forces Radiobiology Research Institute, which supports the Medical Radiobiology Advisory Team, the MRAT. With respect to response activities, the DoD is responsible for responding to incidents that occur on its installations, whatever type of incident, whether chemical, biological, or radiological, and is also responsible for providing response assistance in accordance with Defense Supportive Civil Authorities policy and requirements, with the exception of a special limited allowance for DoD support of the LRN. It's been a special focus of mine since I've held my position to ensure a basic understanding of the DISCA request procedures within the ICLN and the LRN. Thank you, and I look forward to this panel's discussions.
Thanks, Dan, for bringing our attention to the DoD capability and capacities in this space. We have another virtual participant, John Griggs, who will be joining us.
Hello, everyone. I'm John Griggs. Pretty happy to talk to each of you. I developed a few slides, some opening remarks.
John, could you get closer to your mic, please?
Okay, it's actually pretty close. Is that any better?
Yeah, go ahead.
Okay. So I developed these slides, which are based on a white paper developed by the Integrated Consortium Laboratory Networks Radiological Laboratory Response Subgroup, which I co-chaired with Robert Jones of CDC, who's now retired, in 2018. And the title of the white paper is The Tenuous Future of Radiological Laboratories, Addressing the Declining Operational Readiness for Mission Critical Activities of Radiological Laboratories. The primary focus of the paper is governmental laboratories, federal and state, and it's not solely clinical, because in a large radiological or nuclear incident, for example, the results of environmental analyses will likely prioritize which individuals get clinical testing. So it all kind of fits together. So next slide. So the nation's radiological laboratories really face some very serious challenges in the near future that definitely threaten and compromise their ability to support functions that are vital to the missions of their respective agencies, and in particular, to respond to a radiological or nuclear incident. So there's several critical challenges. I'm really going to focus on the three biggest or primary challenges. So next slide. So the three most critical challenges include really a crippling loss of expertise in radiochemistry, which is due to the personnel retirements, kind of coupled with a shrinking number of qualified replacements. Many laboratories have aging and difficult to maintain radiological equipment, instrumentation, and in a number of laboratories, you've got deteriorating facilities that really jeopardizes the generation of data. So next slide. By far and away, the most critical challenge is the number of trained radiochemists is dramatically shrinking. And we can expect a very significant reduction in that number in the next 5 to 10 years. The National Academy of Sciences in 2012 issued a report entitled The Future U.S.-Based Nuclear and Radiochemistry Expertise, in which they noticed in 2012 that 44% of the national laboratory's career nuclear and radiochemistry workforce is 50 years of age or older, and that will retire in the next 15 years. Well, that was 10 years ago. So that number is certainly larger now. Just for example, EPA has one radiation laboratory. I'm the director of that laboratory. In 2024, 60% of our laboratory is eligible to retire. That's not unique in the field that we're in. Part of the problem is there are fewer qualified replacements in academic programs. There's been kind of stagnation in this area for almost since the 80s. Also, there's a need, obviously, for a period of overlap between the retiree departing and the new hire, so that institution knowledge can be passed along, but that gap is rapidly shrinking. So unless we somehow try to address this looming shortfall, there are going to be serious consequences in our ability to respond to an incident. Next slide. Many laboratories have aging equipment that's very near end of life. Equipment is generally expensive. This aging equipment really negatively threatens the ability to do high throughput analyses that you'd need in a large scale emergency response. And even essentially just to keep the capacity and capability to perform mission critical functions for the respective agencies, states, corporate governments, and so forth. Another issue with aging equipment is compatibility with software. For many federal state organizations, there's increasing IT security issues, which make some of the existing instrumentation incompatible, not allowed to use it for that reason alone. So this aging equipment is going to cause significant delays in providing data to inform public health decisions and other mission critical functions. So there's a real need to replace this aging equipment with more sensitive and greater capacity instrumentation. Next slide. Another major issue involves facility infrastructure. At a number of governmental, federal, and state laboratories, we've got issues with the building itself, fume hoods, HVAC systems, electrical systems that are deteriorating. They'll only continue to get worse. Some facilities were built up to 6 decades ago, including a number of the DOE facilities. That obviously decreases the ability to produce essential analytical results if you're dealing with basically the roof caving in. Also, a lot of the newer instrumentation has environmental requirements that cannot be met by a lot of the existing infrastructure. And again, while I said this impacts, the focus here was primarily governmental, federal, and state laboratories, recently a major commercial radiological laboratory closed because of the huge cost it would take to renovate their facility. In addition, these kind of conditions can cause laboratories to shut down. That's happened in the past. Obviously, that has a huge impact on capacity and critical functions in the responding to a radiological incident. So there are other critical issues, but those are the 3 major ones that face radiological laboratories. And the situation is getting dire. Look forward to discussing further with you. Thank you.
Thank you, John, for giving us that outline of the situation with regard to our radiological laboratory systems. Before we go to audience comments and questions, I'd like to ask a few questions of the panel members, and I'm going to direct these to a panel member, but I'd like to also open the floor to other panel members to address individual issues in their systems as well. So I'm going to address this first question to Dan. What can you tell me about the mechanisms? Dan, can you hear me?
Yes, I can.
Okay. What can you tell me about the mechanisms and tools in your systems for coordination and collaboration in the DoD system?
It's really just the knowledge of the various points of contact within the DoD. I've kind of been around, like I said, I've been around within the GS system since July 2012, but I've been involved at the DHA policy level or the DoD policy level since my assignment at the Armed Forces Institute of Pathology, going back to the September 2005 timeframe, when I was the DoD liaison gatekeeper that coordinated with the LRN to put H5 assays on shipboard platforms, type of thing. So my experience goes back to that sort of level. So within the policy offices that are proponent offices of the DLN, nuclear, chemical, biological, health affairs, and policy division, if I don't know who to contact or I'm not the correct person to contact, I can certainly identify who can be that.
So would it be fair to characterize that as an kind of an informal system, and then to also say it's non-institutionalized?
Yeah, it's not institutionalized. It's going to become a little bit more formal. We're rewriting the DoD instruction that establishes and going to republish the DoD instruction that established the DoD laboratory network, and it's going to more formalize that process, hopefully going forward.
Okay, thank you. Any other panel members care to comment on collaboration and communication mechanisms in your systems? Ren?
Sure. And I just want to highlight something that Susan Van Meter mentioned this morning. But, we at CDC have a memorandum of understanding that 9 different organizations have signed specifically for surge laboratory testing during public health emergencies. Prior to COVID, there were only 4 organizations in that MOU, ACLA, APHL, CSTE, and CDC. But we realized during COVID that we really needed to expand that network of engagement and communication with many more organizations in the community, including the AdvaMed DX, which from the manufacturing side, FDA, CAP, NILA, I'm sure I'm forgetting, I know I'm forgetting others, but there are a number of organizations. So that engagement with that community is incredibly important and hopefully helpful, but I think we understand at the same time that it's not enough. Like we need specific commitments to do specific things, which is why we're working so hard on this roadmap.
Thank you, Ron. Any other comments? No? Okay, Beth, I'm going to put you on the hot seat. So with regard to commercial labs, how do they expand capacity in the event of an incident? And then kind of how do you articulate the economic proposition, because you're in business, right, for the commercial labs as well in that situation?
Yeah, thank you for the question. I think I mentioned earlier, like, our strength is our ability to operationalize very quickly and across a large network of laboratories. We have best practice teams that are really amazing, because how do you standardize a test across the system and make sure it's got the quality? We do that really well. They can roll out a protocol. We have set standards. We even, I think we're harder on ourselves when we inspect ourselves. We have a whole team that goes around and inspects our labs to make sure they're done right. And then when we're talking about surge capacity, like during COVID, we had the ability, we had meetings every morning, and we had the ability to move specimens. So if there's not enough capacity in this lab, we could very quickly redirect those specimens so that those specimens could be handled. We did pooling. We were able to direct specimens where we knew at an individual level that they were coming from a low prevalence area, and we could direct those towards pooling because that was a more efficient way of doing testing. So internally, we have a lot of operational efficiencies. Your question in terms of how do you build a business case, I think that's a complex question. If it's a case of needing to do the right thing for the country, I think that's a no-brainer. We're here to be a partner. We're here to be a part of that solution. When it comes to, and this is part of what we're working through, I think with our Public Health 2030 issues, is where do you know when to start and where's the value proposition for that? That's a much more complex question. And I think that's where some of these valued partnerships come into play, so that we're in a better position and we have those partnerships established early on.
Thanks, Beth. Anybody else care to comment on the surge capacity issue?
Yeah, maybe I can just comment from the perspective of smaller labs. I think there are 3 tiers outside the public health response: the commercial reference labs' ability to respond, those larger hospital or clinic-based labs, and then the very small labs who, to be honest, are probably just going to send their testing elsewhere because they don't have the capability. For that middle tier, it really, during COVID and with Mpox as well, came down to what test can I get access to? It truly, for those laboratories, boiled down to which manufacturer is willing to sell me tests and equipment. It didn't always come down to which is the best test. It's just what is the available test. And so that's a critical issue where you have a large percentage of the testing laboratories in the country are having to come to that endpoint of what can I get access to? Of course, there are laboratories like Beth's and mine who are able to develop testing on their own and still had challenges with getting the resources to offer testing. But there's a large percentage of laboratories in this country who just truly were at the position of having to wait for available reagents and equipment. And I think that's something that we absolutely have to address, and hopefully we'll talk more about tomorrow.
Thanks, Matt.
Hey, Dr. Scott.
Yes.
Yeah, this is Dan Harms. One thing that the DoD did very early on was set up a COVID task force for diagnostics and testing. One of the things that they did was go to the FDA to establish a surveillance mechanism that fed over into diagnostic testing. So what they allowed was our surveillance laboratories to use research use only assay, do pooled testing, generally of 5 to 10 specimens. If one of those pools popped positive, the specimens or maybe the individuals themselves would then be referred over to a CLIP registered laboratory within the DoD for the diagnostic testing for SARS-CoV infection. One of the issues that I had to address was that while everybody kind of knows about the FDA, clinical laboratories operate under 2 regulatory frameworks. So there's the FDA that governs and regulates which in vitro diagnostic devices we can use and how they can be used, but it's CMS CLIA that has a regulatory framework for how our clinical laboratories operate. So as where they had gone first to the FDA to get that statement of enforcement discretion, we followed up with CMS CLIA to make sure that they were also on board with that kind of interaction between surveillance laboratory testing with reflex over to clinical laboratory testing. And CMS CLIA essentially implemented that same framework with their university testing statement of enforcement discretion. Thank you.
Thanks, Dan. I'm going to direct this question to John Griggs. John, how do you currently collaborate and coordinate across systems with regard to external partners, and what kind of improvements do you think could be made?
You know, Andy, I think currently the best means of coordination is through the ICLN. The radiation laboratories, I think historically, the way they've been structured, have somewhat struggled with coordination. The Department of Energy labs were so involved in the nuclear weapons program for so long, things were sectioned off. So I think the ICLN currently is the best mechanism that allows for radiological laboratories, whether they're clinical, whether they're environmental, whether they're food, whether they are federal, state, or commercial, to coordinate. I think we can certainly improve on that, but before the ICLN, I would say there wasn't much coordination at all. So that's been an improvement. But I think we still need to work to continue to improve that coordination.
Thanks, John. Any other panel member care to comment? I guess my final question has to do with data standards, and I'll just open this up to the floor. So, with regard to the systems that you're familiar with, do you have data standards and data sharing mechanisms within your systems? And do they enable broad data aggregation to facilitate analysis and information production for decision making? Anybody care to tackle that one?
We obviously have access to a large set of data. We have the ability to aggregate it and share it. It's not without its own data hurdles. If you're a data scientist, which I am not, I like to figure out the story the data is telling me. But we do have the ability to do that. We were able to, during the pandemic, help provide data to the government and other agencies because we can see where the positivity rates are. But I think when we talk about data, this goes back to having a different mindset, right? We have to start thinking about the lab as a strategic asset, right? We are the data center. We don't have data without laboratory testing. And I think shifting that mindset, I know it's a little different than the question you were trying to get to, will help us, but I think that'll help us maybe establish some of those more standards that we need, the minimum data sets that folks have been talking about, and figuring out how to streamline that when we get into that mindset.
Ren?
So first I'll say that my colleague Adi Gundlapalli is speaking tomorrow, and he knows a lot more about this topic than I do. So listen to him tomorrow. But I think the point I wanted to make is that CDC and public health has traditionally set up data systems within programs. Programs tended to be designed and funded around diseases. And it led to a lot of silos being created, and different programs within the public health sector shared data slightly differently. And, I think we at CDC well understand that we've got to move to a much more global standardized system for data exchange. And, we are working really hard to make that happen in the laboratory space as well, so that everyone is using the same cloud systems and using the same data standards. And again, back to the conversation before lunch, I think it was about minimum data sets, and that we start from the same place. But the other thing I wanted to say is that one thing that we're also working on is, and this sort of drills down a little bit deeper, is really focusing on building what we call electronic test order and result reporting systems between our clinical laboratory partners and our public health laboratories. And in some states and jurisdictions, that's been in place. In many others, it has not. And it's really hampered the public health laboratory system's ability to work closely with the commercial and clinical laboratory system. And we think if we can really dedicate a lot of resources to what we call these eTour systems between public and private laboratories to address these public health concerns, that will really enhance our response capabilities.
Thank you. I'd open. Okay. Yes.
Dr. Scott?
Oh, go ahead.
Dan Harms.
Yeah, go ahead, Dan.
Yeah, just a little bit about the CARES Act and the HHS implemented guidance for that. We had a lot of problems on the DoD side with acceptance of the comma separated variable formatted test result records, even though that was one of the formats that was cited in the HHS guidance. We had a lot of problems with the state public health departments not wanting to accept those sorts of test result record submissions, file submissions. And CMS CLIA actually put into its compliance guidance that submission of the test result records was the inspectable standard, not acceptance by the recipient, i.e. the state public health departments for those records. And I really believe we need to maybe try to get the HHS Office of the National Coordinator, ONC, to set the data element requirements and for FDA to be involved on the software medical product clearance or approval side to kind of set that standard that all of the hospital information systems, laboratory information systems need to be able to generate the type of messages needed for the magnitude of public health response that we saw with the SARS-CoV, COVID-19 public health emergency. The other thing with the CARES Act was it was just an overwhelming task for the state public health departments to accept the volume of test result records being transmitted when the normal notifiable disease reporting encompasses only the case testing positive individuals type of thing. So all of the negatives going, I can understand why they were or could be overwhelmed by the volume of data being transmitted. And the other additional issue was when DoD finally got around to establishing a contract to use the APHL Informatics Messaging Services platform, the AIMS platform, we were a little bit surprised that there was a $95,000 one-time connection fee associated with this. And of course, when you're dealing with the type of response that we had with the public health emergency, even though there were often CARES Act dollars flowing down to different agencies, an IT system such as that was not really high on priority of DoD. Thank you.
Thank you. Questions from the floor, sir?
Hi, thanks to the panel. John Hick from Minneapolis. Glad to have some clinical lab and some radiation expertise on the panel. So at times during a public health emergency, we're going to need to leverage clinical laboratories heavily, and we've discussed some of those, but one case study that I'm particularly concerned with is after, God forbid, a nuclear event on U.S. soil, we're going to need absolute lymphocyte counts at scale, and they're going to have to be sequential. They're going to have to be a day or two apart. That population that we need those on is going to be transient. They're going to be on the move, and informatics is going to be difficult. But it's not the usual mechanism is provider orders a lab does the test, returns the results to a provider. But when you have patients that are getting their blood test drawn in a shelter outside New York City one day, they're in Philadelphia 2 days later, and they're in Arizona 2 weeks later when they're going to need care. And if we're trying to prioritize on the fly cytokines and other materials based on the best biopredictors we have, which is how much your lymphocyte counts drop, how do we connect those results with the patient and make sure they've got access to them rather than trying to get back to a provider and one my chart over here, et cetera? So thoughts on that, particularly Beth and Matt.
Ouch, better you than me. No, I can comment on that a little bit. So I think what you're talking about is a portable health record, kind of. And you know, I think we've been talking about that, quite a bit in the medical community, and getting a fixed format for an electronic portable health record. But I think that's a big challenge and a little bit out of scope. I understand it's related, but potentially out of scope for the laboratory itself. But definitely something that's really important to address the public health emergency. So I'm certainly glad that that's on the record for this meeting, because it is a very important issue,
Yeah, if it
and
happens,
not just for radiological emergencies either.
Right, could be for chemical or for other things, but for radiologic
Right.
particularly, if this would happen next week, we're going to have to figure out a unique identifier system, and the clinical labs are going to have to process those. And yeah,
Totally
it's gonna
concur.
be a
Other
mess.
panel members, comments?
I was just going to say, we do have patient portals. You can access your results through your Quest, My Quest. It probably could be improved. When I worked at Kaiser for 11 years, we had patient portals. So there are ways to do this, but we need a better system for sure.
And later, I think
That's specific to the. Can you use
Sorry, I didn't use the microphone either. Go ahead.
That portal is not directly through Quest to the patient, right? It has to go through the healthcare system.
So I'm not the expert on this, but you can get access to your own patient results through the portal. Sometimes it depends on what the analyte is, but you can get access to your results.
Okay.
so. Rain talked about the unknown. So when we have a known pathogen, I would say it's easy, and I'm putting it in quotations because I know that it's not easy. It takes 3 weeks, 15 people trying to put your PCR together and all that stuff. It's not easy. But the unknown, I think that's what I worry the most. Because right now we're doing a lot of targeted testing in all our labs. Micro, West, everybody is doing very targeted assays. We're not casting a broad net. And if I think about how did we discover HIV? Granted, that's many, many years ago, and we didn't have the tools that we have now, blah, 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 blah. It took us 3 years. How did we discover the first SARS? We had to grow it in culture, see that there was a coronavirus in the electron microscope before we could create a PCR and then sequence and then find out what kind of coronavirus you had in there. So to me, the most critical thing is we in our labs, Quest, Emory, all these other places, we keep our positive samples because we are going to be using them for validations or comparisons, but we don't keep our negative samples for more than a week. And we need a lot of freezer space to keep all the samples, and we don't have it. So how are we going to discover the next unknown when we're doing all this targeted testing?
Go ahead.
I'm sure you have an answer too, but I think that's what, I can't remember who was speaking earlier, but there are efforts around agnostic surveillance. So how do you look for the signal in the noise when you don't know what you're looking for? I think there's some interesting technologies around next generation sequencing, but like everything else, it's going to take an investment and infrastructure to change that way of doing surveillance. I don't know, Ren, if you want to.
Yeah, exactly. And I think, Adi, you're talking about this tomorrow, is that right? Threat agnostic? Just a little bit. Well, I think there's a lot of interest across the community in threat agnostic surveillance testing and really leveraging advances in next generation sequencing to be able to, in my mind, and I think in Adi's mind and others, the idea of figuring out a way to collect specimens from sick patients who are not diagnosed with a particular known disease and doing analysis on those specimens to try to look for something that we are not looking for. So there's a lot of work to be done in that area, but I think there's tons of opportunity. And again, we will, the only way this will work is to collaborate with, as Matt said, the hospitals and the clinical labs that are on the front lines that are seeing sick patients on a daily basis and figuring out how to collect those specimens, how to store those specimens, how to access NGS systems that can test, and then
So that's the unexplained illness, unexplained death project that has been ongoing, but then they stopped the funding, and then has it started again?
Well, I mean, from my point of view, I think we're trying to restart it.
Let me go to this side of the room. Please preface your
Just one
comments.
thing on that last question. I'd just
go
like
ahead,
to
Matt.
get
Sorry.
kind of on the record is we really should be focusing a lot of effort on the known potential causes of outbreaks and pandemics and proactively developing prototype diagnostics that in the event they turn into a big problem can be ramped up quickly. We have a good idea of what the possibilities are. Avian influenza, Nipah virus, broad coronaviruses that could, again, or in the future, cause large outbreaks. And we need to take now to start developing those so in the event we can turn that switch on quickly. Just wanted to make that comment.
Thanks,
Hey,
Matt.
on that point, Dr. Scott.
Oh, yeah, go ahead, Dan.
USAMRIID has worked quite hard on that. They've worked with the FDA to do pre-EUA submissions for many of these type of infectious agents. So USAMRIID's been quite active in that realm to do pre-EUAs with the FDA.
Thanks, Dan. Now let's go to the side of the room. Please preface your comment with your name and your affiliation. Thank you. For the record.
Jill Taylor, APHL, previously lab director at Wadsworth. First of all, apology to Ren. You're absolutely right. It's easy to write, CDC should do this in a paper. I get it. But you know I love CDC. And in all my work with CDC, the staff are fantastic. So good for you. And I really like the scheme you put up based on the epi curve. Scott put up a slide this morning that sort of showed the stages but was not dynamic. But this means we're thinking about it. And so that's really cool. After a day, the big word has been complexity. This is going to be hard. It's complex. I get that, but I guess that's why I wanted to start with the minimum data set example, because it's doable. And I think we have to approach this problem in steps that are doable. So just a thought to kind of reset the tension in the room of, oh my God, we can't do this. One other thing, and in a way this may increase the complexity, but I hope not. There are certain things that the national government's got to do that have to be federal, that the national labs have to do. I get that. Funding, Medicaid, data, okay. But then you've got the state level, and then you've got the local level. And in many ways, operationalizing public health action occurs locally. And that makes it a little less complex to think about it, how to do it. And, you know, I did that. We all did that. So in this big picture that we're building, we have to take into account the different levels of systems and where the action occurs, the public health action occurs. And one last point, most scientists are linear thinkers, A, B, C, D. Do we need to bring academic systems thinkers into this discussion to help us? I can't visualize what this looks like, but I'm sure somebody can. So just a thought. Thank you.
Thank you. I'm going to go back to our virtual team to see if we have any virtual questions. Anybody online asking questions? Nope. Okay, over to this side of the room then.
Andrew Pavia, University of Utah. This great panel. And I thought, though, I heard a bit of a disconnect, Ren, between your, and admittedly, it's just a graphic and it's nominal, but between when you would ramp up to taking advantage of our most sophisticated clinical reference laboratories and what Beth and Matt were advocating for. And having lived through multiple episodes where the lab response, was somewhat slow to get rolled out, I actually strongly believe that they're on the right track. So my question is, what would it take to operationalize that and maintain the quality and the sophistication necessary? In other words, what role would CDC play in making a Mayo or an ARUP really produce the right test as fast as possible and be part of the response? And then my second sort of comment, more than a question, is next-gen sequencing is being pretty widely used in the clinical front already. Almost every day we send specimens either to Mayo for bone and joint or to UCSF for CSF or do it in-house. And there's a tremendous capacity out there for next-gen sequencing, which we don't have the informatics to use optimally, but we have the capacity to sequence that is really huge at the moment.
Okay, really good point. And I'm not sure I have a good answer for you, other than we're concerned and we're working on it. But I think, often when I talk about this, partners want to know what the triggers are for, okay, so tell me exactly when you're going to move from public health laboratory testing to commercial laboratory testing, or beyond that to general clinical laboratory testing, and tell me exactly how you're going to make those shifts. And honestly, I don't have a clear, clean answer for you on that. I do, I do appreciate Matt's earlier comment just from a few minutes ago, that where we can do much better and need to think much more clearly about, and I know, Tim Stencil and I have talked a lot about this, and he thinks very seriously about this issue too, is look at the known diseases of concern, and then look at the available diagnostics. And in the past, I think, and this is why we're here, in the past, we, the public health system, operated kind of in our own little vacuum, and we thought that if we deployed assays for all the anthrax and pestis and Ebola, Marburg to our public health laboratories, that we were all set. And clearly, starting with Zika, but obviously with SARS-CoV-2, that paradigm has been blown out of the water, and we need to adjust. And so, what we're now thinking through as hard as we can, and with our partners in the clinical lab space, is how many of those types of assays that exist but don't exist widely, right? They're pretty much most of them are almost exclusively in the public health laboratory. And here I'm talking infectious disease, so apologies. I'm not thinking chem and rad and nuke at the moment. But, can we work like we did with orthopox virus? Can we work to transition some of these traditionally public health laboratory only assays into commercial labs and clinical laboratory settings? Now, that's hard to do, right? It's really hard to do because the public health, these tests have been, developed, as I think Beth said, for, individual tests, manual extraction in a small public health lab with a biosafety level 3 lab, all the blah, 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 blah. And we need, in order to make them useful for a place like Quest or Mayo, they're going to want a high throughput test with automated extraction and on different platforms. And all that requires a tremendous amount of work with FDA, obviously. And we did all that work in an extremely short amount of time, thanks to a lot of FDA enforcement discretion in June for Mpox, but it was really, really hard. And it took a lot of effort on 5 commercial laboratories' part as well. And so, how do we replicate that across 20 or 30 more tests that are known diseases that we're concerned about? It's a big lift. But I think we are honestly working as hard as we can to think that through and to change the sort of traditional paradigm of, here's public health, and then there's healthcare and clinical medicine over here, and we're really trying to figure out how do we work together much more coherently. But honestly, we need funding, and I think the clinical and commercial laboratory sector needs funding for public health readiness and preparedness, and because we need their help, right? We at CDC can't validate, these assays on their platforms because we don't have them in many cases. So we need their help, and that requires effort on their part, and they need to be funded to do that, or they should be funded to do that, especially if it were a large-scale effort across many different assays.
You can imagine that you could take some of these assays with appropriate funding, give them to Matt, tell him now validate this on automated extraction, high throughput.
Yeah, absolutely. I mean, we did that.
We need it.
Yeah, we did that with monkeypox. I think I can't remember exactly how many platforms 5 or 6 high throughput platforms in a matter of a month, thanks to the collaboration with these commercial labs. And, so you can envision us doing that 20 times over with all these other tests that we have sitting on the shelf for these particular diseases of public health concern that are not regularly used in clinical settings. So we're thinking along those lines. We haven't got there yet.
One last quick comment, and this is, I'm just a dumb epidemiologist. I don't do molecular biology. I just play it on TV. But it seems to me that we could take a platform level approach, as we do in vaccines, and say, these are optimal platforms for beta coronaviruses. These are 3 or 4 gene targets we can use. We'll have to change it when we get the sequences of the next pathogen, but we know what target to use, and we know how to do the extraction and optimize the assay.
Okay, you're digging deep, but I'm trying to say.
Brent, I'm going to take you. I'm going to let you off the hook and say, come talk to us. Come talk to Matt and I and our colleagues, and we are here to be your partner and work through this. And this is all part of response readiness, and we can do this together. There are ways we can do this, and it doesn't have to be as difficult as we make it. So.
Just one additional comment is there's one partner who we need to really loop in, and that's our industry colleagues. They are absolutely essential to making this successful. Why did the clinical labs and in many aspects the public health labs struggle? Because we didn't have the equipment, the reagents, the collection material to do the testing in the first place. And the industry partners have to make really tough decisions. I learned throughout the pandemic, they don't have dedicated production lines for COVID-19 tests. They had to decide, do we take an influenza production line and convert it over to COVID, which meant the labs now all of a sudden are going to have influenza reagents. Most labs in the country ran out of sexually transmitted infection reagents because the industry partners had to completely shut those down to convert over to COVID. So working with industry and making sure that they are positioned for success, that they potentially have dedicated production lines that they can ramp up in the event of an emergency is going to make this work. And without their involvement, we'll continue to struggle.
So glad you said that, Matt. It's essential. But I think, Andy, to your point, taking like a vaccine model, there are big boxes with open channels on them that have general purpose reagents, that if we partner together and we bring in our industry partners, there are ways we can get to where we need to be. And because so many people acquired equipment, that equipment's probably in the field. So yeah, we might need a different flavor for this company or this company, but I'm telling you, bring us all to the table and there's ways we can do it.
Thank you. Next question, please.
Thank you. I'm Corey Meyer, Griffin Scientific. So sorry, I ran some more follow-ups for you on the framework, but you said you wanted feedback. So 2 questions. First, I was hoping you could comment on how you're thinking about size or scale of testing, whether it's absolute number versus need, relative to capacity. So that question we had this morning. And then second, a bit of a devil's advocate question. So you drew a distinction between respiratory and non-respiratory diseases. And I'm wondering if there's really a fundamental difference in the way you would respond and who you would partner with, or if it's more a matter of speed. So it's going to escalate faster with the respiratory disease response that's really transmissible, and where you get to, it's a much higher testing demand that you end up with. So, food for thought.
Yeah, so in terms of your last question, that's a good point. And honestly, we're still working through the analysis of the role, what we think could be articulated in a national
roadmap in terms of roles and responsibilities for all those different players, given those different scenarios. And you may be right that there's really no difference from a testing capacity scale-up point of view in the roles of the partners if it's a respiratory disease versus a non-respiratory disease, and that what that may be simply impacting is the rate of increase in cases and how quickly we would move, from a small response to a much higher level response. But I guess I don't know the answer to that yet, and I think we need to work through the methodology to check that. Sorry, and remind me what your first question was. Sorry. I know it was a hard one that I was trying to avoid.
First question was of how you're thinking about defining size or scale, thinking about those testing phases and whether it's need or absolute numbers.
Yeah. Sort of same answer, which is we're not sure yet. I think these are, again, this comes back to this idea of triggers. And sure, we'd like to get to the place where we can identify very specific triggers that say, okay, we're now out of initial response phase and initial surge phase, and we know we're now in, expanded surge phase. And in expanded surge phase, we have to call Beth or Matt or whatever. I don't see it as being quite that simplistic in reality. And so, I think at this point we're approaching the methodology, in real general terms, and not. I don't think we've answered that particular question yet. Sir.
Hi, Ryan Maves. I'm here representing the Society of Critical Care Medicine at Wake Forest University. There was a question earlier about what sort of the entry point for the Department of Defense would be for research and surveillance and laboratory-based collaborations, and Mr. Harm mentioned a few options. I am a recovering Navy captain, relatively recently out, and haven't quite lost the haircut yet. There are multiple points of entry into the DoD, particularly when it gets down to things like public health surveillance and laboratory work. And I would just posit that, especially for folks in the Beltway, the simplest point of entry is one of two for a public health emergency of this nature. Either the university down the street at Uniformed Services University in Bethesda, across the street from NIH, or the Naval Medical Research Center and Walter Reed Army Institute of Research, which are located in the same building over in Silver Spring. The community of people who do this in the DoD, despite its size, is a relatively finite group who know each other. And either of those would be a very simple way. And I mention those just because that's how we responded internally within DoD to COVID. It was a group of like-minded people who got together using the university, NAMRIC, and RARE as our kind of meeting points, and then started to push out towards the operational forces, towards the fleet, to get these kinds of responses together and use those consistently as a forum throughout. And also to partner with academic civilian colleagues and other partners in government as well. So just to say, give you something to write down for that.
Dan, do you have any comments?
I think we're kind of talking about two different things. What I mentioned in my introductory comments was the defense support of civil authorities activities of the DoD that requires mission assignments from the Federal Emergency Management Agency to queue that assistance as provided. I know very early on in the COVID response, there was a mission assignment for diagnostic testing assistance submitted to DoD. It never really got implemented, but there is a prescripted mission assignment for laboratory assistance testing that has been, again, pre-positioned by the Office of the Undersecretary of Defense for Policy, who has control of the DISCA program within DoD. So I think more of what we were talking about is operational procedures that the captain was talking about is operational procedures, policy type mechanisms versus actual diagnostic testing.
Certainly, and if I may just briefly respond, absolutely, that's absolutely true, sir, Colonel. But the counter-argument is the NAMRIC and RARE have operational control over a number of the pre-existing diagnostic labs with existing relationships with the laboratory network run by CDC. And it's relatively, for example, in San Diego, the Naval Health Research Center is already a partner lab for surveillance and diagnostic testing purposes for respiratory viruses for CDC. We can leverage pre-existing relationships in place. In the beginning of the pandemic, for example, that's what we did, is used NHRC's lab to support not just defense testing, but also testing for the greater population of Southern California. Over.
Any additional comment, Dan?
No, but like you said, the Naval Health Research Center, the U.S. Air Force School of Aerospace Medicine, the Epi Laboratory, Armed Forces Health Surveillance Division, all of those folks have connectivity to the CDC for surveillance. The Armed Forces Health Surveillance Division has what they call an ESSENCE program where they extract data out of the medical records of diagnostic testing that is done, and they do share that information with the CDC. So there are quite extensive data flows between DoD activities and the CDC.
Thank you. Our resident vet.
Hi. Thank you. Joe Anelli with National Association of Federal Veterinarians. I wanted to come back to something that Matt had brought up before. I didn't want to let it go as a sort of a passing comment, but it needs to be a central theme of what we're talking about today. You had raised the question of how do we prevent the next pandemic, and you suggested that we look at things that we know about that are most likely, like avian influenza, and now it's mutating into multiple mammalian species. It seems like it might be the next organism to mutate sufficiently for efficient human-to-human transmission. So now that we know that, how do we overcome our human nature of ignoring, just waiting for it to become an absolute disaster before we actually react to it? We're a responsive species, I think. We wait for something to get bad before we jump on that. So we have an opportunity, and it's something, I've been doing a lot of my professional career working at the White House, working on the avian influenza and pandemic preparedness plan. And here we're still working with H5N1. There's no funding because someone had also mentioned that the folks that provide those fundings have short memories. But here we are again dealing with H5N1, dealing with something that's now in the U.S. When we wrote that plan, it was not in the U.S. yet. It's killed more birds now than in history in the United States. Where do we then take the veterinary diagnostic lab results of where avian and mammalian species are turning up positive, and when do we start incorporating into the clinical diagnosis of an influenza-like illness and simply writing it off as a common cold or perhaps influenza without a diagnostic test to determine what the cause of that is and whether or not it's an A or B influenza and whether or not it's an H5N1 or something else?
So I can start. You've pretty much just summarized my last 3 weeks. And I think there's reasons to be encouraged, and I'm seeing a lot of progress. And I don't want to steal too much of the thunder from tomorrow's discussion because a lot of that's going to focus on this particular issue. But 3 weeks ago, I was thinking about avian influenza and needing to stand up diagnostics, and I got an email from CDC partners saying we want to talk to you about partnering on potentially expanding testing. That's a really great sign. Kudos to Ren and team and the CDC group for doing that. I'm also talking with multiple industry partners about avian influenza, and it wasn't on their radar because there's not the the monetary incentive for that to be thinking about it. But now with COVID, it's a lot easier to talk about preparedness than it was before. And so I think that we're making good strides. I've directed the clinical virology lab at Mayo for a number of years, and this is the first time where I'm starting to have these proactive conversations about things like this. So reasons to be encouraged.
Yeah, I'll just add, and with a caveat that we have an entire division at CDC dedicated to influenza, and I'm not in it, so I'm not speaking for them, but I do work with them, and we've been working with them extensively for many months now with regard to H5N1. And helping them reach out to our clinical laboratory partners to engage on this topic. But again, just so hopefully you're not too scared, we do have a well-developed influenza surveillance system and diagnostic system in the U.S., right? So influenza A testing is widely available in our clinical and commercial laboratories. And through our influenza surveillance system, a percentage of those influenza A positive tests are sent to public health laboratories that have the H5 specific test. And so, we have a reliable public health surveillance system that we believe strongly will identify a human case of H5N1 through the combination of clinical lab testing for influenza A, public health lab testing for H5. Nevertheless, we are, as Matt said, working hard to think through, should we be expanding the capacity for H5 testing in the clinical laboratory setting or commercial laboratory setting, and that's actively being discussed right now. It is important to also say, I think, that the clinical treatment really won't change between an influenza A positive or a H5 positive. So I think we do have a reliable system to identify those influenza cases and treat them, even if we're relying on the public health laboratories to do the H5 diagnosis for the time being. Thank you. We have time for the last two questions. So, ma'am, you first.
Can you hear me? Okay. All right. Sujata Rashid. I work for a nonprofit company called ATCC. And I actually am the program manager for one of the government-funded programs we manage as ATCC. This is called BEI Resources. It is an NIH-funded biological repository through which we make reagents and make it available for assay developers, also for other people, but I'm just focusing on assay developers at this time. This is more of a follow-on to what Beth said about tech transferring assays from perhaps the CDC, who's usually developing the early assays, and then tech transferring it to the commercial side. Just want to use this opportunity to create an awareness that we have the tools and the reagents, and we have partnered with the CDC with the poxvirus group, and would also like to offer our services when you all have to get to the table to work on the next big one. Thank you.
Thank you. Final question?
Sure. I'm Rob Middleberg from NMS Labs. Sort of a continuation of this. And I'm a little bit of an outsider, I guess one could say, but a little bit of a disturbing theme I've heard, although Beth alluded to maybe a solution, is that there appears to be this linear process where it's, federal government, APHL, and maybe the commercial labs. I just want to promise you that the commercial labs are filled with wonderful scientists who can develop all kinds of tests in a hurry. And I'm not sure, we've had our own experiences with APHL labs in that we know you exist, that's nice kind of a thing. And it's hard to get to the table. But I think there might be some surprises here that if you bring us to the table at the beginning, commercial labs, you might find that solutions can be had a lot faster and really technically sound solutions. So it's just more of a comment, I guess, and going out on a limb a little bit, and I know I'm really in a minority here, but just an observation that I've been hearing.
I will say, just from my experience, and correct me if I'm wrong, if you have other experiences, but I know, like just from my experience from the contracting world, that sometimes it's difficult as a Fed to reach out to commercial labs or to any commercial entity directly. There's kind of protections in place to not prevent it per se, but to keep the playing field level. So if we were to reach out, it'd have to reach out to everybody, essentially, to not give unfair competitive advantage, essentially, to anybody. So there are some challenges with that. Not that that's insurmountable, but I think, it makes it a little more difficult.
So I'm just going to be provocative and say we got to get over that. But, I mean, honestly, Matt and I were talking about
Talk
this.
to the
before
lawyers.
session. I know the attorneys are going to get in. I'm not an attorney. I don't play one on TV. I'm just a scientist. But at the end of the day, when we think about the ecosystem of the lab, there are key players, and there's not a ton of us. Like if you just think about the key commercial labs, just say, if you want to play, come to the table here, but we have to figure out a way to get over that, or we're never going to get to where we need to be.
Yeah,
I don't have the solution today. Yeah. I'm not an attorney.
I mean, from the action officer level, from the people who want to solve the problems, that's not where the speed bump is. So we're getting advice from our contracting officers and our attorneys and things like that. So it's like, I want to reach out, and then I get
the science is the easy part.
Yeah,
That's what I always say.
Any other final comments from the panelists? Open floor? Okay, hearing none, turn it back over to the program team. Thank you, panelists, especially our virtual panelists.